Good evening, everyone. Welcome you all to G. Bhanu Prakash Medical Academy Remarkable Rapid Revision 2.0 for the subject of psychiatry, presented by myself, Dr. Tilak Dixit, and thanking you all for joining us on this Sunday evening. You're sparing time for this beautiful session. Okay, psychiatry is a subject which has a good amount of clinical questions that are really confusing sometimes. So, today we have crafted the session in such a manner that when you solve the psychiatry, you'll get to know that it is an art of solving MCQs, and you will believe that when we have gone through this session, after knowing this prerequisite knowledge, you will have a better understanding of the subject of psychiatry and you will enjoy solving the MCQs. Why? Because when I say solving MCQs, I mean to say that particular subject has particular diseases in it and how the case are presented and how the examiner is asking questions on that. Psychiatry is not just about knowing the psychosis and neurosis, it's way beyond that. Psychiatry is about knowing the diseases and knowing bits and pieces of those diseases when pertaining to the examination, because in India, most of the cases of psychiatry that are coming to the psychiatry department, not every case is a heavy schizophrenic case. There are more illnesses apart from schizophrenia as we go in the session ahead. So, how we have planned this session today? So, in the subject of psychiatry, we planned a session for you that is Remarkable Rapid Revision 2.0. Okay, so what we are bringing in this session, first of all, we will be taking care of all the important PYQs of your previous sessions which have come. Okay, previous 5 years at least for the FMG and NEET PG as well, because both the NEET PG and FMG have been crafted by your National Board of Examination. So, we've taken all those questions into consideration and made this one wholesome session for you guys. Now, we've taken all the one liners in this session. Okay, everything is a one liner. Okay, so now, having said that, we have taken a diseased approach. Okay, what is this disease approach? So, disease approach is we've taken this particular disease and we have given you highlighted points about each diseases. So, there are at least 50, 60 plus diseases that we have discussed in this session. We have almost around 200 one liners. This session is going to be a really wholesome for the subject of psychiatry. Now, whom is this session for? First of all, if you are a student who has done and dusted with the psychiatry and knows psychiatry end to end, this session is a revision for you guys. Okay, so better watch this session from first point to the last point. Now, if you are a student who has half-heartedly studied the psychiatry, know few terms, bits and pieces about it, so this session you will get this diseased approach which we have taken and those peculiar one liners that you need to know about the diseases. So this half will get converted to another half and will make it one. Okay. And if you're a student who has studied nothing and come here for the first time revising psychiatry with us, mind you that this session will give you a basic good amount of knowledge that you can rely upon and build over this knowledge as soon as possible, and also you can get some good insights about the subject. And if you are a student who is just preparing for the examination, come here for the first time reading psychiatry just to skim about it, and this session is going to be useful for every one of you. So without further delay, we should start. Okay, so my friends are here. Okay, so this session is going to be in English, and the English part is for the other one. Okay, so starting with our first one liners. Okay, disease based approach, schizophrenia, a peculiar disease in the psychiatry, and the psychotic disorder schizophrenia is a chronic psychiatric disorder with symptoms lasting for at least 6 months. Now, when I say it chronic, it has to be more than at least 6 months. Okay, and this is the point where the examiner is crafting questions. Like, when do you call this case as a chronic schizophrenia or a chronic psychiatric disorder when it has presented for more than 6 months? Now, it looks easy, but it has been asked at least 5 times. Okay, 5 times. Now, this tells us how a question in psychiatry will be framed. Number one, they'll give you the diseases. Number two, they'll ask you the duration. Okay, brief amount of illnesses for this much amount of days, months, and year, and this will decide the name of the disease. Okay, so the name of the disease and the duration, both of them are really really important. This is how the question is framed. Simultaneously, we'll be looking at how the questions will be framed. Okay, so thank you guys for joining. Kinesh, Tanya Firdos, Arjun Patel, Irfan, Ahmed Khurshid, and Arjun Patel. Arjun Patel. Okay. Thank you so much for joining this Sunday evening. So let us start. So first one liner is done and dusted. Schizophrenia and psychotic disorder is a chronic psychiatric disorder with symptom lasting at least 6 months. Now, core features of any schizophrenia: delusions, false but a firm belief which cannot be changed on the contrary. Okay, that is the definition. Another way the examiner will craft question is on the definitions. So, number one, diseases, number two, definitions, and number three, the durations. Okay, so I'm opening up you the mindset of the examiner, how the examiner will craft the questions. Now, the hallucinations, okay, hearing things, listening things, and perceiving things that are not in a reality format. Okay, we'll go ahead in this session and discover what hallucinations exactly are. Disorganized speech. You and me are talking like good, bad, and we are having a good, nice conversation. But a person with a disorganized speech, you are not able to figure out what the exact person is trying to say. अरे भाई कहना क्या चाहते हो, ये बात हुई, ठीक है? So it's disorganized speech. Negative symptoms. Now, this part, ladies and gentlemen, this part of the negative symptoms is very very important. When it comes to negative symptoms, the examiner is interested in asking you what are the famous negative symptoms. First one is the flattened effect, second is the evolution and elogia. But overall, flattened effect is very, very important. Now we will take the fourth approach of solving questions. That is clinical scenario based question. Either they can give you a disease, they can ask you duration, or they can give you a clinical scenario like this. Say, for example, a person is there and a death occurred in the family. Death in family. Everyone is crying, everyone in a sorrow, everyone in grief. But this person shows no cry, no laughs, no talk, and having a flat expression. Okay, so everybody is crying around, everybody is in a sorrow, everybody is in grief, but this guy is having no emotion. Scenario number two, scenario number one, scenario number two. This person, same person, is sitting there in a circus. Okay, everyone is enjoying, everyone is laughing, everyone is making sure that they're having a good time, but this person is showing no cry, no laugh, no talking, and having a flat expression. Okay, so when things are not in a favor, he is not reacting. When things are in favor, he is not reacting. So the effect, the mood is just like a straight line. That is a flat effect. Clear with the concept? Because this is your previous year FMGE question. Okay. Now, Bluer's 4A symptoms. Bluer's 4A symptoms. What are those symptoms? Affect disturbance. That is the mood disturbance. Autism, ambivalence, and association loosening. Okay, all these fours are important. It should be on your tips of your fingers. Okay, because the examiner is crafting question directly from the Bluer's 4A. So I will put it in a red box so that when you revise this annotated PDF, you will have a good look at these boxes and you can revise out of these 201 liners. We'll have this good boxes so that you can revise at the end moment because sir has marked it for you guys. Okay, also if you like to share your feedback, you can connect with me on my Instagram that is Dr. Tilak Dixit, right to right underscore the underscore left. Okay, so you can put your name, you can provide me with your badge or your queries, and I will try to answer your queries as soon as possible. Your queries, your feedbacks, and whatever problem you have, your solutions, your problems, everything you can ask me, and whenever I have time, I'll respond to you. Okay, moving ahead with today's lesson. So I welcome all my other friends who have joined us in this session, Lawrence and Pratyush Paral. Okay, so we are reading psychiatry in a very different manner. So the things that we have learned in the past and the things we are discussing it today are really, really different. First thing, we are taking a disease based approach. Second thing, we are talking about the duration. Third thing, we are going a feature based. And all these three are the methods in which the examiner is framing question. And we have got you the very best content when it comes to psychiatry, because this is remarkable rapid revision 2.0. Okay, first trying symptoms for the schizophrenia, auditory hallucinations. Okay, person is hearing things which are not there. Okay, so how a case will present in this scenario? A person is there and he says he is listening commands. Okay, he's listening commands. And when you ask him why you done this thing, so he says that somebody has told me in my ears, I'm hearing those voices and I'm responding. So this is a classical example of auditory hallucination. And why I'm talking about auditory hallucination so much is because it is the most common hallucination overall. Another box for you guys. Okay, now next first trying symptom is thought insertion. Okay, so I am not doing this thing. Somebody has inserted the thought into my brain and I am responding to this situation. Okay, thought withdrawal is the opposite of it. So I was thinking something else, but somebody took the thought away from my head. Okay, that is thought withdrawal. Now, delusional perception. Okay, a false perception. I'm suspicious about someone, that this person might be conspiring against me, and that is delusional perception. Okay, so what is a delusional perception? I'm having a false but a firm belief that this guy is having a conspiracy against me. So what exactly do I mean by the first time symptoms? First time symptoms, for you guys to understand, like if you're sitting in the OPD, a person comes with the auditory hallucination. So someone is talking to me, someone is giving me commands, someone is inserting their thoughts, someone is taking away my thoughts, and I'm having a suspicion about that person. These kind of symptoms, if they are talking about, this is the first time symptom of the schizophrenia. And mind you, most common hallucination is auditory. And this, my dear friend, has been your previous year question in the FMG at least 3 times. Okay. Okay. Moving ahead with the treatment. Now, what will you do as a treatment? So, first line is the atypical antipsychotics. Okay. So, examiner will ask you about. So, Dr. Parv sir is here with us. Good afternoon, sir. And thank you so much for your comment and really obliged. Thank you so much. And your session was really nice, sir. Okay, so the first line, a typical antipsychotic is risperidone and olanzapine. Okay, so the first line treatment. Okay, they'll ask you about this particular line. Although this looks really, really simple and easy, but how they frame the questions, whether you will give the atypical antipsychotic or the typical antipsychotics. Okay, so now keep one thing in mind. Okay, forget about anything else. Sir has told that is the first line, atypical antipsychotic, example risperidone, olanzapine. We'll go through these names again and again as we go ahead in the session. Okay. Clozapine is used for the treatment of resistant schizophrenia. Okay, so you're sitting in the OPD, person comes to you with the schizophrenia, you have taken the first rank symptom, you know the lowest 4A symptoms, and then you prescribe a treatment, goes home, takes medicine, comes back with the same symptoms for more than so many days. So it's a resistant schizophrenia. So what drug will you use in that case? The examiner is interested in asking about the clozapine. And when I write the clozapine, I have a famous ADR associated with it, it is a granulocytosis. That is the most important ADR. Well, it has five more other ADRs, but the examiner is interested in asking about which drug causes a granulocytosis when given to a resistant case of a schizophrenia. Or they can frame you a question like a case of a schizophrenia was introduced to the drug that made a condition to develop more infections in the patient. Why does it happen? Because of the granulocytosis. And what the examiner wants to ask is about the clozapine. Got it? Okay. Moving ahead. Moving ahead. Thank you, Dr. Per. Thank you, Dr. Per, for encouraging me and being with our student. And your presence has made this session really good again. Thank you so much, sir, for sparing time for our session also. Schizotypal disorder shows eccentric behavior, odd beliefs, not fully psychosis. Now, word about schizotypal disorder. Okay, how does this word look like? So it is looking like a typical schizophrenia. Okay, how would a typical schizophrenia would present? A person with a eccentric behavior. You guys are here and he is staying here. Okay, eccentric behavior away from the people, and you guys have a belief. You believe in these thing, and he believes in some or the other thing which is unrelated to you. An odd belief. Okay, odd belief. You believe in star, he believes in moon. Okay, and not fully psychotic. Okay, but this word, ladies and gentlemen, this word doxab is very important, not fully psychosis, and this makes it a typical schizotypal disorder. Okay, so this is a disease based approach I was talking about. In the psychiatry, we're going to study about a diseased based approach. Okay, paranoid schizophrenia. You know n number of things about paranoid schizophrenia. Okay, you know n number of things about paranoid schizophrenia. That person is suspicious, person is this, person is that. But it is what kind of a delusion? It is a delusion of persecution, and this is very very important. Okay, so we're learning the diseases, we're learning the one liners, we're learning the pyqs, we are learning the durations, we are learning the first line treatment, second line treatment, we are learning about the ADRs. And this is how comprehensively we are studying psychiatry. Okay. So now, catatonia. Okay. So the examiner is framing continuous questions on catatonia and what? Waxy flexibility. Waxy flexibility. A person is having an odd posture like this. Okay. So if you try to mold him like this, he'll mold like this. If you try to mold him like this, he'll mold like this. So this is what? This is what? Waxy flexibility. He's flexing like wax. You can mold him in any direction you want. Okay. So you can mold him in any direction you want. So you can make him lie down, you can make him rest. But a person of a catatonia will stay in this posture for prolonged period of time. So how will we treat him? Sir, we'll make him sleep by benzodiazepine and ECT as of now required. Now coming to the ECT indications. Are you guys following this session? How you guys are liking this session? Please let me know in the comment section below. Is the speed good? So you have to catch up with the speed because this is remarkable rapid revision 2.0. Okay, ECT indication. First one is the drug resistant drug resistant schizophrenia. Now, major severe depression, suicidal tendency. Apart from that, not taking drugs, not taking food, and the one which we are talking about is the famous catatonia. Now, the electric current duration was previously asked in INICET and also in the NEET PG, and then it was repeated in one of the FMGE sessions also. So the current duration is 0.06 seconds. Okay, so when ECT is now not routinely done, but when we guys were doing it, so we were using those probes for the ECT patient, and it was charged for 0.6 seconds, and you need to press two buttons and it will deliver the charge. And post ECT, the person develops congestion in the eyes. Okay, so these were some old question, but it can come up anytime in the examination also. 0.7 second by RF. And somebody said severe depression, RF. Very good. You are following the session very nicely. How long this session will be? Priya ji. So this session will be at least 2 hours, minimum 2 hours. Okay, but I'll try to finish it as soon as possible, with keeping in mind that you guys follow this subject of psychiatry when I'm talking about on this remarkable rapid revision 2.0. Now, delusion disorder, non-bizarre delusions plus normal functioning, non-bizarre delusions. Okay, so delusion are there, but they're non-bizarre. That's not a way ahead when we are talking about the delusions. Delusions, you have some delusions that I believe that if I write with this pencil, I'll get good marks. This kind of a false belief, but you have a firm belief, and that cannot be changed contrary. But is this hampering the world around? No, is it not? So this is kind of a non-bizarre delusion. Okay, I'm not talking about that you are having a non-bizarre delusion. This is just for the example purpose, and it's not hampering the functionality. Okay, I'm just giving an example to make you realize that what this disease is. So examiner sometime ask you about the delusional disorder. So how do you define delusional disorder? Is a non-bizarre delusion with a normal functioning. Okay, moving ahead. That's good. We will get time to revise other subject also. Bilkul. I will make sure that you get ample amount of time to revise other subjects also. And I will make sure that when you are sitting here, I'll utilize best of your time. Coming to the schizoaffective disorders. Features of both schizoaffective disorders has two Fs. Okay, it has two Fs. So it has two points. First is the mood disorder, and the second is the psychotic disorder. A condition in which we have a mood disorder and psychotic disorder staying together. It's schizoaffective disorder. So when they're talking about two things, remember that there is a condition which has two F's in it. Okay, this makes your life really simple when it comes to psychiatry, because psychiatry has lot many diseases with lot many subtypes, and these are subtypes. Schizotypal, we knew it. It is sounding like typical. Okay, so as in eccentric behavior, and schizoaffective have a two F, that it is talking about two things, mood and the other one. Okay, brief psychotic disorder, another diseases, symptoms for less than 1 month and full return to the pre-morbid function. Now coming to the situation again, this person had some bizarre symptoms like not wearing clothes properly, not doing things properly. He is behaving weird, weird behavior. Why? Because he lost his job 1 month back. But later on, after 20 days of this whole thing, after this bizarre behavior, weird behavior, and everything, he returned back to its own original state, and he has realized that life is good. We can move on. Okay. So, what in this 1 month? In this 1 month, he was taken to the doctor, and you are the doctor sitting in the OPD, and this guy presented in 20 days. So, okay, I'll rub this off. Okay, so this guy presented to you on day 20. Day 20 in your OPD. You're sitting here. So this guy is having a weird behavior, lost job in last 20 days or 1 month, and he's coming on the day 20 in your OPD, and you term it as a brief psychotic disorder because symptoms is less than 1 month. And the examiner is interested in asking you questions like this on the durations. Risk factors, family history, cannabis use in adolescent. Okay, so scenario number two. This is scenario number one. Now, scenario number two, they will frame question like this: a 17-year male school going child has a history of cannabis and it was found by the parents and withdrawn. Now the child presented with a weird behavior. Weird behavior. Now behavior. Okay. So this guy comes under a brief psychotic disorder. Okay. Two classical examples. They will frame you questions like this. So enjoying the sessions? Now, mood disorders. Mood disorder, major depressive disorder, persistent low mood, anhedonia, more than 2 weeks. Now, more than 2 weeks. Major depression, more than 2 weeks. Major depressive disorder, persistent low mood, anhedonia. And what is anhedonia? What is anhedonia? My friends will answer in the comment section below. What is anhedonia? I'll come up to this as soon as my friends answer. The first one to answer, I'm waiting for you guys to write it in the comment section below. What is anhedonia? Is it something related to the depression? That's the hint. Okay. Now, symptoms. Okay, Arav has answered it. Lack of previous pleasurable activity. Lack of interest is also there. Okay. Lack of previous pleasurable activity is the answer for this anhedonia. And this, why I'd ask you this question, because this has been repeated in the FMG and the NEET PG examination at least 2 times in a row. Okay. So this can come up. 2, 3 times repeated questions that can come up. Okay. Inability to feel pressure. Okay, very good. Okay, very good. Priya, very good. Ahmed, Khurshid, and Arjun Patel, and also Arav, the first one to answer. Symptoms: sleep appetite changes, low energy, poor concentration, guilt, and suicidal things. And the classical question, probable question you'll face in the examination is about the SIGECAPS mnemonic. Okay, what is this SIGAPS mnemonic? So just remember, S stands for your sleep. Okay, I stands for your interest, then your energy, which is low, then your poor concentration. G stands for your guilt, and suicidal. When they are giving you this in the exam, okay, they'll give you bouncers like this: SIGECAPS. What is it? It is what? It is related to the depression. It is not related to delusion. It is not related to other condition. Not this thing, not that thing. They'll classically ask you about the depression. Think of the common things in the exam and think of this probable probable question. Okay. So I've marked you questions, I've given you boxes, I've marked your previous year questions, and I've marked your probable questions. A one session which is having everything in it. Melancholic features. Okay. Sometimes they are asking questions on the melancholic feature. It is also severe loss of pleasure, but psychomotor retardation is the feature they are asking you. Because as soon as you see a severe loss of pleasure, previously pleasurable activity, what you will mark? Anhedonia. But melancholic features is having a psychomotor retardation. So it has a difference from anhedonia. And this is the point the examiner might frame question and confuse you. But since you have gone through this session on Bhanu Prakash Medical Academy, the remarkable repetition 2.0 by Dr. Tilak Dixit on the subject of psychiatry, you will not make this mistake. Okay, atypical features. Atypical features of the depression. You already know: mood reactivity, hypersomnia, or latent paralysis. The mood is altered all the time, the person is sleeping all the time, and he's behaving as if he's paralyzed. He can't move his limbs up. I cannot move my limbs up. I cannot raise my arm. I cannot lift my head. I cannot close my eyes. I cannot open my eyes. I'm sleeping all around. This is a atypical feature. Okay. And mind you, hypersomnia and latent paralysis might come up in the next examination, because since it was asked in the previous examination also. Okay. So that is why this one liner is framed. Okay. Now, dysthymia. Dysthymia at least asked 3 times in the FMG and 3 times in the NEET PG as a solo question, and as a feature based question. So really, really important to know about dysthymia. It is nothing. I'm seriously talking about it. It is nothing. It's just a chronic mild depression which is more than 2 years. Okay, more than 2 years. Okay. Now, treatment about the depression. If the mood is low, we will elevate the mood by what? By the SSRI. And what is the famous SSRI? Fluoxetine. Okay, I have taken here CBT and ECT. So this can come up as a option number one. This can come as the option number two. This can come up in the option number three. And in the option number four, they might give you ECT as the first line. Okay. So your mind will tempt you to answer on this point. Okay. कि sir, बहुत ज्यादा डिप्रेशन है, मेजर डिप्रेशन है, the person is not moving anything, the person is not doing anything, just give him shock and he'll be fine. No sir, that is the wrong answer. First line is the fluoxetine, followed by the cognitive behavior therapy, and ECT is only given. So the answer to this question is ECT is only given. We've already taken the indications of ECT in the above part. For those friends who have joined right now, we've taken already the ECT indications in the first part, and my friends have answered it really, really beautifully. So ECT is only required when the suicidal or severe person is there, not taking drugs, not taking food and everything. Now, major depressive disorder with psychotic feature. Okay, so this particular I have taken for your concepts only. This might be important for solving question. What do you call a major depressive disorder with psychotic feature? How do you treat it? Actually, you treat it with two things: antidepressants for the major depressive disorders and the antipsychotic for the psychotic features. Okay, so having said that, I already know that you know about psychotic feature and your other features. Okay, so I'm not elaborating on this point because this is just remarkable rapid revision. We are going to see only things which is coming up into the examination. Okay, we're going disease wise, we're going symptoms wise, we're going duration wise. We are taking those important probable questions that might land up in your examination, and this session is very, very important for you guys. Okay. Okay, we'll come up to the drugs like fluoxetine and paroxetine as we go in the session ahead. But right now, you have answered it correctly. Suicide risk. Talking about suicide risk in the psychiatry. Okay, the very particular problem that every psychiatrist face, a suicide risk, is greatest at which stage? It is in the earlier recovery phase. Okay, so how a person will frame a scenario based question here, that will give you that one patient was there, was taking antipsychotics and your other drugs for the major depressive disorder. 1 month later, he has improved symptoms. So the family believed that the person is having no problem. So they stopped the medication. The person had a revert back symptoms, but this time attempted a suicide. Okay. Okay. This is just for the teaching purpose. Okay. This is just for the teaching purpose. Okay, so did this, and this happens in the earlier recovery phase. That's what the examiner might frame questions in. See how the examiner is going deep into the session. Okay, now coming up to the risk factor. Whom can do, whom are the person who are willing to take up their life? Okay, so ones who have done the prior attempt, one who is hopeless, worthless, and a recent loss of job, family member, and finances. Okay, finances, job, family member, recent loss, hopelessness, worthlessness, helplessness. Okay, helplessness, and prior attempts. Okay, and this is your FMT integration also. A person with the prior attempts have a, like, what you call it, a suicidal attempt in which he has done a wounds over his forearm. You find a wounds over his forearm. These are the hesitation cuts. So this is just for the integration with the FMT. Okay. Are you guys following this session? You guys liking this session? Okay. Aram said hopelessness, helplessness, and worthlessness. These are the peculiar feature. Now, coming to the drugs, fluoxetine is approved for use in the children. Examiner will frame a question here that you know drugs about the adults. Okay, you know everyone. 1 lakh people is sitting in the FMGE examination and the NPG examination know that fluoxetine will be given, but they're asking you drug which can be given in the children and it is the approved drug. It is also the same, which is fluoxetine. Okay, so we have to learn like this. Okay, bipolar disorder 1 and bipolar disorder 2. Bipolar disorder 1 has a mania, depression, mania, depression, mania, depression, mania, depression. Okay. Bipolar 2 has a hypomania and a depression, hypomania and a depression, hypomania and a depression. Okay. But for that, I have to frame a simple isoelectric line. Okay. Now it is clear. Now it is clear. After this line comes up, sometimes we have to draw a line in between. Okay, that's a metaphor from my side. So bipolar depression disorder part one has a mania depression, mania depression, mania depression. They can give you a image based question graph like this. Okay, they can give you a graph like this. And bipolar disorder two, they can give you a graph like this, and by this you can make. Okay, so is it visible now? Is it visible now? Audible, visible, screen is moving good, up and down, everything good? Okay, now clear. Okay, sorry for this disturbance. Sometimes it happens. Sometimes it happens. Okay, these things happen sometimes. Coming to the mania. Okay, someone who is having mania, how do you call that person is having a mania when it is having a elevated mood? Okay, increased activity, running here and there, decreased need for the sleep and graduosity. Okay, so these three features are really, really consistent for the mania patient, and the examiner will frame questions continuously around this part. The person presented with the elevated mood, flight of ideas, and increased activity, running here and there, and was not sleeping, not even sleeping 1 hour in the night. This person will be termed as mania when you're writing the prescription, having mania features. Okay. Okay, now coming up to the mixed episode. Sometimes the examiner is framing questions around the mixed episode. Okay, for those of my friend who have recently joined, we've taken a case scenario based approach to the psychiatry. We are talking about the durations, we are talking about the drug treatment, we are talking about the common ADR, we are talking about the age group in which the disease can present, we are talking about the definitions, we are talking about the PYQs, we are taken the one liners. So, in this eight manner, we are studying psychiatry in a very different manner from those which you have listed or learned above. Because this is what? This is a remarkable repetition 2.0. Okay, mixed episode criteria for both mania and depression nearly every day. Okay, just remember that sometimes they are framing question around the mixed episode. Okay, so almost every day a person is having mania, depression, mania, depression, mania, depression, mania, depression, and this is 1 day. Okay, so sorry. Okay, mania, depression. This is 1 day, nearly every day. Okay, that is important for you guys. Now, rapid cycling has been continuously coming into the examination. Who are the rapid cyclers? Have more than 4 episodes of mood disturbance per year. Okay, so they will give you a person had a treatment started in 2023. Since then, it presented with more and more features, and it is having a feature 5 times 5 mood disturbance features in a year from 2023 to the 2024, and now in the 2025 you're seeing the patient. So how will you classify this patient? Rapid cycle, slow cycle, frequent cycler? Nothing, only the rapid cycling person. Okay, so the first line treatment, if the mood is getting disturbed, we will take what? We will take a lithium. Okay, first drug you need to remember is lithium, second drug is valproate, third drug is carbamazepine. Okay, just remember these simple algorithms. Okay, now in the psychiatry, in the pharmacology, you have bunch and bunch of tables, you have bunch and bunch of classification, but that bunch and bunch of classification won't help you exactly to solve the question, although it is very very important to remember that whole classification. But for the exam purpose, that one line that will change the game in the examination as far as the FMG is concerned, as far as the need pitch is concerned, INICT is concerned, or whatever you're studying, this one line will make a change. Remember three drugs and then you can build over it when the time allows. For time being, it's lithium, valproate, and carbamazepine that will be taken as a mood stabilizer. Lithium carbonate. Very good. So, are you guys following this session? Are you guys following this session? How are you liking this approach? A simple, easy way of learning psychiatry, one by case scenarios. You guys liking it? Please tell me in the comment section below. Lithium has side effect, tremors, hypothyroid, nephrogenic diabetes mellitus. Okay, just a second. Okay, tremor, hypothyroid, and nephrogenic diabetes mellitus. So they will frame a question into the examination. A person with a mood stabilizer, lithium, presented in the OPD with symptoms like tremor, hypothyroid. He's having a range T3, T4, TSH, and coming with the nephrogenic diabetes insipidus. And they might ask you about the drug. So the common side effect about the lithium you should know. This is a ADR based question, and this later on develops into lithium toxicity when not given in a therapeutic dose monitoring way. It develops diarrhea, tremors, confusion, and it has to be treated with the dialysis. Such a big problem in this particular slide, such a big problem. Okay, so we're talking about just a second. Okay, okay, so we're talking about such a big problem: tremor, hypothyroid, nephrogenic diabetes insipidus, and then it can lead to diarrhea, tremor, confusion, and now the patient will require a dialysis. Okay, so this is a very big problem. That is why there is a therapeutic dose monitoring for this. Okay, and there is a index which I have mentioned in the above part. If you guys are attentive, you will answer in the comment section below what is this value we are looking after, and this, if this value exceed, the patient is going in this way. Okay, my friend is telling normal lithium is 0.6 to 1.2 liters per liter. Okay, that is the normal value, 0.6 to 1.2. But what is this value which we are looking for? If more than what, it leads to this part. Okay, I'm asking this question. Your answer is correct, but I'm not asking for. Okay, 1.5 is also a good answer. So it's ranging from 1.5, but severe thing occur after 4. Okay, so 4 is a better answer than 1.5, but although if you're exceeding 1.2, you're going to 1.5, you might land up in the lithium toxicity, but the answer examiner is looking for is 4. Okay, 4 is severe. Yeah. So Abdullah Sheikh wants to say, sir, when you're starting a new topic, please mark the topic with the highlighter so that we can understand in which topic it comes. Okay, I'll take care from the next time. So we're talking about now another drug, valproate. It is having a severe teratogenic effect. Now, what I am trying to tell you, lithium, you need to know about that one line. Then you need to know about the therapeutic dose monitoring. If it doesn't happen, it leads to your toxicity. Now, in the valproate, just remember this one line. Valproate is teratogenic and it has to be avoided in pregnancy. Okay, got it? Yes, 4 is severe and it requires a dialysis. So the examiner is looking for this answer. Okay. Coming to a very another famous drug, lamotrigine. Okay, and this leads to a famous problem which is known as the Steven Johnson syndrome. Okay, so lamotrigine triggers Steven Johnson syndrome. Okay, so lamotrigine has a trigger. So it triggers what? It triggers Steven Johnson syndrome. Okay, this is just a way of remembering things. This is how our memory works by association. Okay, now ECT is effective for severe mania and depression. Okay, they will ask you about this part. In which condition you will give ECT. Okay, we've already discussed in the session above. Okay, now other mood disorders. Now we are talking about other mood disorders. Talking about the cyclothymia. Okay, so cyclothymia is what? It is a fluctuating hypomaniac and mild depressive symptoms for more than 2 years. Now, as soon as I hear the word cyclothymia, so how a cycle moves up and down, sometimes the pedal goes up, sometimes it goes down, sometimes it goes up, sometimes it goes down. So there's a fluctuating hypomania. It's sometimes going up, it's sometimes going down, sometimes going up, sometimes going down. That's the way I learned it when I was preparing for the psychiatry subject. So fluctuating hypomania and mild depression, because cyclothymia, dysthymia, and everything comes under the depression. So it has a very mild quality of depressive symptom, but hypomania which are fluctuating. And this is happening at least for 2 years. Okay. So this is very, very important. The single line is very, very important. Now, the next part, seasonal affective disorder. Okay, so what is the seasonal affective disorder? It is obviously linked with the seasonal pattern and response to light therapy. Now, a scenario. A person comes to you in the OPD. He feels bad when winters come. When winters come, so he's dull, he's depressed, he's dull, he's depressed, and he's feeling really low. But as soon as summers come, he's good. He's good. Winter slash rainy season, both of them are having clouds, so both of them are having a low lighting conditions, so the person feels dull, person feels low and depressed. Okay, sometimes happens with every one of us. By the time of evening, especially the Sunday evening, we are thinking what we are doing in life, why we are not focusing, why everything is going bad, why doesn't the morning happen. Okay, happens with us also. So when it is happening around the seasons, when the examiner is asking about the seasonal pattern, so it is a seasonal affective disorder. Very, very important. They might frame questions like this according to the season change behavior. Okay, very good. Now, anxiety and phobia disorders. Okay, and the generalized anxiety disorder. इन तीनों में क्या कॉमन है? Excessive worry for more than 6 months, various domains. Now, for the anxiety, phobia, and generalized anxiety disorder, one thing is common, the duration. And that the examiner is asking, because you guys have mucked up the anxiety, phobia, and generalized anxiety disorders like water. You've gulped it like a water. So now the examiner is clever, is asking you whether these guys know the duration of anxiety, phobia, and generalized anxiety disorder or not. Okay, so he's asking you about those questions which are duration based, more than 6 months. And this kind of new pattern question have been recently adopted in your FMGE examination, January, past January session and July session. Especially, they kind of ask these questions in the January, which is upcoming. Okay. Now, panic disorder. Panic disorder. Okay, okay. But before that, there is a whole list of the phobia that you have mugged up by this time. If you still haven't mugged it up, one question might come in. examination. So get that list, and that's a really long list of mysophobia and this cynophobia and fear of fire, fear of strangers, fear of this thing, fear of that thing, fear of water, hydrophobia, water, and everything. Okay, so सर ये सीजनल वाली बात रिलेटेबल लग रहा है, बिल्कुल तभी तो बोला है, रिलेटेबल होता है, सबके साथ होता है ना? फोबिया ट्रीटेड विद systemic desensitization and flooding. Very good. I'll come to this again because since my friend has mentioned it, so phobia, you need to learn about the table, which I'm not discussing right now. Also, the systemic desensitization. So, what is systemic desensitization? Okay, so basically, if you are afraid of spiders, I will give you a small toy spider in front of you. Then I'll increase the size of the toy spider. Then again, I'll increase the size of a toy spider. And then I will make a paper spider. And then I will make a soft toy spider so that systematically you get desensitized by these spiders again. But I'll not give you spider in your hand. This is just for your teaching purpose. Okay, so systemic desensitization is also a method to treat phobia. Well, flooding is nowadays not used. It was really considered a good therapy, but since now things have changed, flooding is not used really. Okay, flooding is basically flooding with the information, flooding with all the phobias. ज्यादा फोबिया डाल दो ताकि पुराना फोबिया बैठ जाए, ठीक है? पर it doesn't work every time. Okay, so the point here to stress is the duration. Now, coming to the panic disorders. Panic disorders, sudden recurrent panic attacks. Now, this is fairly very common, and that's why I'm highlighting this panic disorder and this recurrent panic attacks. Okay, everyone of you might have felt it some way or the around. Okay, some way or the around, you are having sometimes panic attacks. Okay, so when you're having a recurrent panic attacks like palpitations, sweating, fear of dying, impending do. When the examiner frames question, they will give you hints like this on the impending doom. Okay. And when it is coming recurrent, it is a panic disorder. Okay. They're asking you question about whether you know panic, whether you know about recurrent panic attacks, or whether you know what exactly do we mean by panic disorder. Okay. Yes. Okay. Nice. Treatments of the panics are by SSRI, CBT, and short term benzodiazepine. Well, this particular key statement stays in the psychiatry for a long time. That's why I'm not discussing things like this. This is just for telling you that when the case will present, you know the situation, you will listen to the session again and again, you know the treatment of the disease also. But this stays everywhere in the psychiatry. So you can learn this sentence and you can use it in the multiple places. Agoraphobia. Now, coming to the agoraphobia. I told you I'll not discuss the whole table. I'll discuss you the only important. This is one of the phobia. It has a fear of places. Agoraphobia has a fear of places. But how will you remember? Gora person is having a fear of places which are having which are having a very good amount. Gora person is having a fear of place where light is too much. Okay, so the gora person will get a reddish person. He will develop a reddish complexion. जितने गोरे लोग होते हैं धूप में जाके रेड रेड हो जाता है, ठीक है? So the gora person is having a fear of places, just for remembering. Okay, not exactly like this, and where the escape is difficult. So the examiner will, this is the memory trick, this is the memory trick, but the examiner will give you a scenario. Acrophobia is the fear of height. Very good. They will make a scenario that the person has been into a cottage or has been into a mahal, and he is fearing because he cannot go outside, can't go outside. So he's staying somewhere in and can't go outside. So he's having a fear of places where the escape is difficult. And that's how you solve a question of agoraphobia. Okay. Why I'm discussing a simple scenario in front of you, because you know agoraphobia, but when it comes to the examination, you will not be able to apply it very easily. Okay. Social anxiety disorder, fear of embarrassment in the public. So, examiner will give you a scenario that the person is having difficulty in public toilet while urinating. Okay, so he don't use the public urination urinator when he wants to have a maturation. He's not going to the public toilets because he's fear of social people, that the public will be there and have to face public. Similar, a person, okay, okay, a person. Okay, there's some problem. Okay, now it's good. A person is having a difficulty in adjustment when goes to a wedding, just like you and me. We don't like going in the weddings. Okay, so we are also a kind of a social anxiety disorder person. We don't feel comfortable there. Okay, so there is a continuous embarrassment that the examiner will give you in the examination. Claustrophobia means fear of closed spaces. Very good. MRI is an example of claustrophobia. Specific phobias for specific objects or situation. Behavior therapy is effective. Now, behavior therapy. This key statement you can use anywhere when phobia word comes. Behavior therapy. Okay. Now, OCD. OCD. Many of us have OCD, obsessive thoughts, compulsions to act, and the first line treatment is clomipramine. Okay, sir, we knew something else, but why are you telling clomipramine? अरे रुको जरा सबर करो ठीक है obsessions first we'll know the obsession continuous thoughts okay so these will be the thoughts why I've written a thought in the bracket because you need to know that obsessions are thoughts they are not action and compulsions are action why I'm framing this because the examiner is interested in asking you what exactly do you mean by obsession sir OCD में obsessive compulsive disorder तो बोल रहे हो पर obsession क्या है और compulsion क्या है? Obsession are the thoughts and compulsions are the actions. Now the first line treatment is clomipramine. Okay, very important. This first line drug SSRI is clomipramine. Okay, insight is often preserved in OCD, and this is a negative part of the one-liner that has been recently framed and has been given in many books and framed at least three times in NEET PG, and for the FMGE, it is again three times. Has been asked in your examination that insight is often preserved in OCD. Okay, the person is knowing what he's doing. Okay, but he can't control his. That's why it is compulsive acts. Okay, I know that hand washing causes dryness of hand, but what do? I need to wash my hand. है ना हर बार बंटी का साबुन स्लो नहीं होता बंटी को ऑब्सेसिव कंपल्सिव डिसऑर्डर भी हो सकता है ठीक है ओसीडी का डिफेंस मैकेनिज्म अनडूइंग होता है बिल्कुल ये भी एक important one liner hai. Right now it's not coming up in the examination but still it is very important and Arav is answering really nice also Ahmed Khurshid Arjun Patel and yes Pratyush Baral everyone is answering really good I like students who are really interactive also do tell your feedbacks on my Instagram ID Dr. Tilak Dixit or right to right the left okay now body dysmorphic disorder okay preoccupation with the perceived defect now I'm looking fat I believe that I'm looking fat I believe that my hand is not looking great but I believe that my face is not good I am having a continuous thoughts that I am not looking good and this terminology is really being used by our celebrities that I'm having a dysmorphic disorders and everything. So it is what is having a preoccupation of thoughts. I'm having a preoccupation of thoughts. I'm already perceiving that I am having this problem and perceived defects. Okay. I'm preoccupied with my thoughts and I'm having a perceived defects. Okay. Okay. Now, PTSD, post traumatic stress disorder, intrusive memories of the past trauma. Person is avoiding those circumstancing, hyperarousal, and it is treated with CBT and SSRI. Now, the scenario they will give you scenario number one, a person was in the room and the room was lit by fire, and the person somehow escaped or was rescued. Now wakes up in the night, avoids going to places having fire, and have continuous flashbacks. So what is this case? This is none other than the post traumatic stress disorder. Scenario number two, the examiner will frame you a question that the boy comes in emergency department. Okay, why do I write energy? Why do I write energy? It's EMR department, and the child is having some injectable. Later on, has flashbacks, continues, avoids going to the hospital, wakes up in the night, and this is PTSD of the injections. Okay, same situation, two different scenarios, two different questions, two different examinations, FMGE and NEET VG. Okay, that's how we have studied the whole syllabus for you guys so that we can make one single line very, very important for you guys to understand. Okay, so I hope you're liking a session. Okay. Now, acute stress disorder, PTSD like symptoms, avoidance and waking up of night and everything, same situation, but less than 1 month. Okay, that is acute stress disorder. Though examiner is interesting in asking this difference. Okay, so they'll give you the same scenario, the same whole scenario, this whole same scenario, and then they will mention it is less than 1 month. So it is an acute stress disorder and not PTSD. So see how the examiner will frame questions and trick you in the examination. So the scenario number one and scenario number two, they'll mix these things up and they'll ask you questions regarding this. So this one slide is really, really important. Okay. Simplified or not, somatic symptoms and related disorders of somatization. Okay, multiple unexplained physical symptoms cross multiple systems. Okay, what exactly do I mean to say it is a somatiform disorder. In simple words, somatiform, that means it's body and it's having multiple presentation. The person is having a abdominal pain, he perceives that he's having a difficulty in breathing, and also having a chest pain, also having giddiness, also having bone pains. Okay, so multiple systems, system on 1, 2, 3, 4 and 5. Okay, so this is somatiform disorder. We're talking about the disorders. Earlier, we were talking about the schizophrenia, the drugs, then depression, then cyclothymia, dysthymia, and then phobias and everything, PTSD, acute stress disorder, and now we have come up to somatiform disorder. Okay, so what exactly do we mean by somatiform disorder? It is having a different presentation of other organs, major organs. Okay, multiple unexplained physical symptom across multiple system. That is very, very important. Yes, PST visits to multiple doctors just to confirm the diagnosis. Very good. Very nice. Retrograde amnesia, flashbacks, like physical symptoms. Very good. You guys are following it nicely. Okay. Good. Hypochondriasis. Everybody knows it. Still, one line you need to know about hypochondriasis. A person like someone who is preoccupation of having a serious illness. And this I have personally seen in OPD many times. A child has been brought by the mother, or the mother comes up and says that my child is having a problem. I am having a problem. I'm having a disease. Doctor, please see me. This is the disease. This is the problem. So, no, ma'am, you are preoccupied of having a serious illness. We run through the test and we have facts in front of us that you don't have a disease. Okay. So medical branch works on facts and not merely opinions. Okay. Well, opinions are important, but facts are there to prove the case. And we talk on paper and on facts. That's why you don't have illness, you have a preoccupation of having a serious illness, you land up in the category. Okay, sorry. Huh? Okay. So you land up in a category known as the hypochondriasis. Now, what is the difference between the conversion disorder, how the conversion disorder is different from hypochondriasis? Because earlier in my days I used to think that hypochondriasis and conversion disorders are one and the same thing, and this confusion of me was picked up by the examiner and asked as a question into the examination, because the conversion disorders are neurological symptoms like paralysis, blindness, which is inconsistent with the pathology. Okay, so now the patient specifically presents you with a condition. Sir, I'm not able to see. Although my eyes are open, but I'm not able to see. Okay. Although I'm having my hand, but my hand is not able to raise up. I'm having a paralysis of this hand. And then you check the motor, tone, powers, and everything. You see in his examination, your light reflexes and all, and you believe that there is no neurological symptoms and he's not having a pathology. That is conversion disorder. And hypochondriasis is a belief, preoccupation of a thought of having a serious illness. It doesn't have a physical features, and that merely is the difference. See how this slide is important. We're coming to, okay, excessive feelings. Doctor shopping, yeah, doctor shopping is seen in this case. Very good. Excessive feeling is good. La bella indifference. We're coming to that in a short while. Conversion disorder means neurological symptoms. Very good. Tanya Firdos. Fear belief, la bella indifference, medical student syndrome. Oh, very nice. This medical student syndrome. Okay. Coming to your favorite topic, Anil Pant and Tanya Firdos. La Bella indifference. Okay. So indifference इस शब्द से मुझे क्या याद आता है? Inappropriate lack of concern in seen in conversion disorder. Inappropriate lack of concern. That is the whole definition. And this can come up as a definition based question or a feature based question. Okay, how feature based question will be framed? This particular theme, which is lack of concern seen in the convergent disorder, is what? This is a feature based question. How definition based question? What exactly do we mean by the labella indifference? What our friends was talking about was the lack of concern, and this particular lack of concern, indifferent electrode. Okay, there was one electrode in the ECG which is not showing any potential, although it is connected but not showing any potential. So that is, my dear friend, indifferent electrode, and that is la bella indifference, which is inappropriate lack of concern. It is seen in the conversion disorder. Okay, are you guys following this? How you liking the session? Do let me in this comment section below, and you can also join me and share me your feedback on Dr. Tilak Dixit Instagram, RIGHT 2 WRITE underscore the left. Okay. So these handcrafted one liners are specially designed for you guys so that you can come up with great answers in the examination. We've taken 8 approaches to solve one question, and we have carefully made these one liners because this will come up in your examination. You will thank me on this ID as soon as your exams get over. Okay. Having said that, factitious disorder. We're coming to the factitious disorder. Okay. Factitious disorders. Intentional production of symptoms for psychological gain, not external reward. Okay. But sir, I have also heard similar thing in malingering. Okay. So sir, we are discussing factitious disorder versus malingering. As we've discussed PTSD, acute stress disorder, as we have discussed this particular thing, hypochondriasis conversion disorder, we're bringing you confusional terms right after the other so that you don't land up into the examination when you are will land up in a problem into the examination. Okay, factitious disorder is the intentional production of symptoms for psychological gain, not external reward. Malingering is intentional production, ladies and gentlemen, for external incentive, money. Okay, so malingering is for money. And factitious is providing facts, intentional production of symptoms for psychological gain, just for fame. Factitious is for fame, and malingering is for money. Okay, now I've simplified it enough. जानबूझ के झूठ बोलेगा फॉर सम रीजन. ओके, सो मैलिंगरिंग से याद रखिए क्या रीजन हो सकता है. बहुत अच्छी बात बताई आरव आपने. आरव, यू वेरी नाइस. यू हैव टोल्ड दैट मैलिंगरिंग मीन्स जानबूझ के झूठ बोलना फॉर सम रीजन. बट व्हाट इज दैट सम रीजन? एम स्टैंड्स फॉर मैलिंगरिंग and M stands for money. Money is the reason. Whereas the examiner will ask you that the person is producing intentional symptom, but he's not seeking any reward. He's just being a person who tries to be in the center of the universe. Okay, he wants fame, not money. It's an F stands for fame, F stands for your factitious disorder. Clear? Clear hai? सीधी बात, no bakwas. Walk to Heaven 123 is from Nepal. Welcome, Walk to Heaven. Priya Kadam, maligning for secondary gain. Very good, Priya Kadam. Maligning means जानबूझ के, ठीक है? Like money problem. Tanya Firdos also answered it correct. So I'm believing that every one of you are liking the session. Okay, thank you so much for this appreciative comment. It means a lot to me. Alcohol withdrawal के symptoms हर exam में पूछे जाते हैं. Alcohol is a problem which is fairly more common in our setup, in the Indian setup, and this is a very distressful situation when the alcohol withdrawal person comes up with the delirium tremens, hallucinations, seizures, and DT is delirium tremens, T is tremors. So initially it starts with the tremors. Later on, it goes all the way to the delirium tremens. And this is inappropriate things which is seen by the patients. Not really things. Sometimes he sees a pink buffalo. Sometimes he sees different fan is being a big fan like aeroplane fan. It's some weird objects. As you're not able to follow these weird words that I'm telling you, these things are seen by the patient sometimes, along with the delirium tremens. That's a dreadful situation when the alcohol withdrawal is there. When you know about the tremor, hallucination, seizures, and delirium tremor, need not to elaborate too much about it. But alcohol withdrawal presents you with 1, 2, 3, and 4. At least 4 features you'll be able to answer into the examination that can come up as a feature-based question. Now, delirium tremens, coming to the very, very important part, delirium tremens. Okay, so delirium tremens is confusion, autonomic instability, hallucination. But, ladies and gentlemen, as I told you, it is a visual hallucination. Sometimes a person is seeing the things which are not even existing. He's sitting in the farm, he's sitting in the field having alcohol. Sometimes the alcohol is withdrawn, and then sitting in the farm thinking about alcohol, and he sees a pig buffalo at the night. Is it happening really? No, is it not? So, this is a visual hallucination. So, this kind of scenario might be framed up into the examination. Confusion, autonomic instability, hallucinations can be fatal to treat. Sorry, it can be fatal and has been treated with benzodiazepine, and that is your first line treatment for delirium tremens. Now, Cage symptom, Cage questionnaire is again for alcohol. Very nicely told by Tanya Firdos. Very good, very good, very good, very nice. Thank you so much. Cage questionnaire is for your alcohol withdrawal, and you have to learn that this can come up as a one liner. Tremors for 24 to 48 hours, more than 48 hours. Seizure, good, 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 good. Cage, audit, must, and DAST are the questionnaire features. You guys are awesome. You guys are studying really, really well. Thank you so much for studying it so beautifully and making my work easy. So now I am moving to the question which comes up. I should write it 100% in all exams. And if I write it, this will be the most correct statement of today. Wernicke's Korsakoff, confusion, ataxia. You know Wernicke's Korsakoff even more than me, but still you need to know the feature because it comes up as a retrograde question. They'll give you that the person is having confusion, ataxia, ophthalmoplegia, memory deficits, and this is a case of a what? Korsakoff syndrome. One case Korsakoff syndrome. Scenario number one. Scenario number two, they'll give you that the person was diagnosed with the Wernicke's Korsakoff syndrome, and what are you treating him with? So we're treating him with the thiamine. We're treating him with the thiamine. That is another way they might frame the question. And after the giving of thiamine, they perceive that the symptom is better, or the person feels that the symptoms are gone. So having a very good relief by the thiamine is a characteristic feature of Wernicke-Korsakoff syndrome. Very, very important one liner. Moving on to the common withdrawal symptoms, like after you withdraw from the alcohol, you don't get sleep, you feel tremors, you see hallucinations. Okay, common withdrawal symptoms. Okay, so how a question can be framed: after withdrawal of this alcohol, what will be the first withdrawal symptom that the patient presents to your hand? As I mentioned, it is first insomnia, followed by tremor, followed by hallucination, and goes upway to what? The delirium tremens. Okay, got it? अरे yes or no, yes or no लिख दो यार. Got it or not? Okay. Coming to thiamine deficiency. Yes, global confusion of thermoplegia and ataxia. Very good, Anil Pant. Tremors, ataxia, thiamine deficiency. Thiamine, yes, yes. First up thiamine, then dextrose given for hypoglycemia. Very good. Best, best, best. Doing it awesome. Good, 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 good. Okay, everyone is following. So, thank you so much for being there. And now we're moving to opioid withdrawal. Opioid withdrawal, and this again comes up 100% times in all exam formats. Opioid withdrawal, opioid and alcohol are the common problems in India. So, after opioid is withdrawal, the person comes up with the lacrimation, yawning, piloerection, and the diarrhea. Okay, so every part is leaking. That's how our professor used to tell us, that every part leaks when your opioid is being withdrawal. Okay, so opioid withdrawal is fairly more common in the distant peripheral parts of a city, and mostly in the northern states. Okay, so lacrimation, yawning, piloerection, and diarrhea. These are the features of the opioid withdrawal. And as my friends might write up the drug of choice for the opioid withdrawal, okay, in the comment section. I'm waiting for the answer. Yes, sir, we are so focused that we forget to comment. That's acceptable. Thank you so much. But comment what is the drug of choice for the opioid withdrawal. I'm waiting for the answer, and Priya Kadam has answered it correctly. Naloxone. Ladies and gentlemen, naloxone has been asked many a times in the FMGE examination, and that is why it is very, very important. And I'm continuously asking you questions, because that is what is important at this stage when I'm going for the FMGE examination next month, and for the NEET PG examination few months later on. Okay, opioid intoxication, respiratory depression, pinpoint pupil, and naloxone is the antidote. As we've already discussed, this is very, very important. But the person presents with how this opioid withdrawal, opioid intoxication person presents with the respiratory depression and the pinpoint pupils. These are the 2 points that the examiner will ask you anytime when they are asking about the opioid intoxication. Now, buprenorphine has also been mentioned. Very good. Naloxone, naltrexone. Very good, very good, very good, very good. Respiratory depression. Okay. Coming to the pinpoint pupil, another condition in the medicine, which Dr. Purvis mentioned in the medicine lectures also. So, what other condition presents with the pinpoint pupil? It is pontine hemorrhage. Pontine hemorrhage. Very, very important. Now, coming up to the cannabis, acute intoxication, euphoria, perceptual distortions, or motivational syndrome. Now, this particular line, or motivational syndrome, has been solely associated with the cannabis, and that is examiner's favorite part when they're asking about cannabis, because euphoria, you already know, some of you have already perceived it, and perceptual disorder distortions, like stairs have been looking like as if they are going to the heaven. This is an example of perceptual disorders. And a motivational syndrome is examiner's favorite. And as my friends have mentioned it, Dhartura is a roadside plant poison. Okay, very good. Also a railway poison, if I'm not wrong. Okay, stimulants like cocaine and amphetamine intoxication. Now, if you take cocaine, like Kabir is saying, you'll end up in agitation, tachycardia, withdrawal, depression, and suicide risk. So you'll end up sleeping most of the time and you miss Preeti's wedding because you have taken cocaine. And that is a stimulant, that is an intoxication, that is having agitation, tachycardia, withdrawal, depression, and suicide risk. Okay, very, very important. Disulfiram is used for the alcohol aversion. Everybody knows it. Need not to elaborate too much, but disulfiram, like reaction drugs, might come up in the examination. Disulfiram, like reaction drugs that you need to study for the examination. Another drug which has to be avoided with disulfiram is very common drug used in India, that is metronidazole. Metronidazole. So person comes up with the alcohol and later presents you with the acute gastroenteritis, has taken disulfiram. Now you cannot give him metronidazole. That is very, very important. And my friends have answered it very correctly. So that means you guys are awesome. Coming to the naltrexone used for the opioid and alcohol dependence. Smoking cessation, nicotine, you already know, varenicline and buprenorphine. So this is one, this is two, and this is three that you need to know for the smoking cessation. Very, very important. Okay. So in this one liner session, we have taken about smoking cessation, opioid, alcohol, other substance withdrawal, and we have taken only the key features that you need to know about in the examination. See, psychiatry will give you a question which is very pinpointing, very sharp, very straight questions. And if you get that correct, if in any examination you land up with 10 correct answers, automatically your score will get boosted fairly. In some subjects you might not get a good score, so this will create a good balance. So that is why it is very, very important for you to read such a one liner. Although it looks simple, nicotine replacement, you already know it, buprenorphine, you already know it, varenicline, you already know it, but still it is required for the examination. And keep on revising important stuff, because you are at the G. Bhanu Prakash Medical Academy, Rapid Revision 2.0 by Dr. Tilak Dixit. Coming to the child and the adult psychology, psychiatry. Okay, so the very famous topic, ADHD, attention deficit hyperactivity disorder. It is inattention hyperactivity for at least what? For at least 6 months and before the age of 12. And the examiners are asking in questions like this because you already know it is inattention and hyperactivity. But for how many days? It is for the 6 months and before the age of 12. And these are the two important one liners that you need to study. Drug of choice is methylphenidate and amphetamine. Very good. My friend Arv has already answered it before I come up with the answer. Very good. Aversion therapy, pleasurable stimulant convert into non-pleasurable. Very good. Somnia Shake 5548. Nice answer. Everybody has answered about the metronidazole. Okay. So, moving on to the treatment, already my friends have mentioned it before me, methylphenidate and amphetamine. Okay, coming to the autism spectrum disorder. Okay, so the label for the autism spectrum disorder have been asked previously into the INICT examination. Okay, so it is a social communication disorder, deficits, repetitive behavior, and early childhood onsets. Okay, of you guys have already watched a Good Doctor series. Many of you have already gone through Manius Khan movie, and many of you have already watched Autism Spectrum Disorder Kids. So you already know that they are not fairly good at communication, and they do a repetitive behavior. And it is early in the childhood onset, and they are different kinds and need help and need a good partner like you and me to understand them, because we are not only studying for the examination, we are also studying to know a particular thing about particular disease so that we can help the society in a better way. Okay, come up with behavioral disorders. Okay, Rett syndrome. Rett syndrome has been asked previously into the examination. Rett syndrome, it is a regression after early normal development, hand wriggling in girls. So Rett syndrome is associated with wriggling, ring, wriggling. Actually, it is wriggling, but I'm writing wriggling. Okay, with the girls, Rani. Okay, red ringing Rani. So red having ringing moments in Rani, which is girls. Okay, just a way of remembering things, not really presented like that, but just for the remembrance. Specific learning disorders having impaired in the reading, writing, or maths, which is dyslexia, which is most common. The movie we already know and has been giving us post-traumatic stress disorder since ages. That is, I mean, but dyslexic child, specific learning disability, writing problem, reading problem, learning problem, math problem, अक्षर जो कि नाचते हैं ऐसी problem seen in dyslexia. Coming to the conduct disorder. Now, you do a disorder which is not supposed to be happening at your age and not supposed to be happening according to the law. So, repetitive violation of the rights, social norms in children. Okay, now who is doing this problem? Doing this problem, who is doing this problem? It is done by a child, and a child is violating the laws, rights, social norms. It is known as the conduct disorder. Now, coming to the oppositional defiant disorder. Okay, a good name, good amount of a name. Okay, so what exactly it is? A angry, defiant, vindictive, and does not violate basic rights as in the conductive disorder. Another comparison, ladies and gentlemen. Another comparison, my dear students. So now the students are asking questions to each other, which is also very good. Okay. So meanwhile they answer their questions, I'll have a water. Okay. So now they are asking problem and they're giving simultaneous answers also. That's really important. That's a good vision from my side to see all these things. Conduct disorder and oppositional deficient disorder, ये दोनों अलग अलग disorder है. इन दोनों में difference क्या है? डिफरेंस क्या है? एक में राइट्स का उल्लंघन किया जा रहा है, राइट्स आर बीइंग वायलेटेड इन द कंडक्ट डिसऑर्डर, वेयर इज द oppositional defined disorder is an angry person, is a defined vindictive. That means he is angry with something but still he is not violating the basic rights. Okay, so oppositional is in the opposition of things and the norms which is going on, but still not defying the laws and order. Sometimes we are also in that state. We are angry with some laws and things and the society norms. We are vindictive, we are defiant, we are angry, but we don't violate the rights. Sometimes we are also in the oppositional defined disorder. But well, this case presents in the OPD, having a serious concern to be heard and listened. And as a psychiatrist, as a person who is seeing the OPD, we are here to hear all their concerns. Okay, so the more fairer common phenomena is the conduct disorder as far the exam is concerned. Separation anxiety, everybody have felt it. Fear of being separated from attachment figures. If I say this line anywhere down the line, in the session, many of you have already gone into a flashback that I do not want. We are learning here at the G. Prakash Medical Academy, remarkable rapid revision. Just for your orientation, in the psychiatry subject, we are learning about the separation anxiety, fear of being separated from the attachment figure, and that could be a person, family, thing, place, money, or anything. Okay, so I need not to explain this part, at least for now. Enuresis. Enuresis is the repeated urination in the inappropriate places after the age of 5, treated with the desmopressin. Okay, so desmopressin, also imipramine for the nocturnal uresis. Okay, but the age is important. Inappropriate urination at the age of 2 is acceptable, but at the age of 6, it is not acceptable. Enuresis. Neurocognitive disorders like dementia, delirium have acute fluctuating attention. Okay. Now, I'll first take the example of delirium. Okay. Fairly common phenomena. Desmopressin more than any pramide. Okay. Very good. following the questions, following the answers. Actually, imipramine, when the word comes nocturnal aneurysis, you'll mark the word imipramine first. Okay, that's given in the books. Acute fluctuating attention, disorientation, hallucinations, and which are reversible. Okay, so consider a scenario in which a person is having a high grade fever like 102 plus, and he is not able to concentrate. He believes that he is in a state of a cloudy consciousness. Okay, so now you as a doctor perceive that he's also in a state of a cloudy consciousness, having disorientation to time place person, and having hallucination. He believes that he's somewhere in the sky and now his life is gone, he's going up to the heaven. Okay, and as soon as you give up the paracetamol, inject those drugs, get his temperature down, he's again in a good fair state. So in this 102 fever, he is having disorientation plus hallucination plus attention problem and fluctuating consciousness. But as soon as the treatment is resolved, he is a better person. Now, this fairly is a condition which is reversible, better in condition. So, as you can see, that this condition is reversible when the drug is given. So, this is your delirium. Okay, and that comes up in the neurocognitive disorder. First up, calm the environment and environment provide to the patient. Very good, Arav. You guys can be a good psychiatrist. You know that? Believe in yourself. You can be good one. Okay, and many of you also might be thinking about medicine, surgery, gynecology, pediatrics, whatever branch. Also tell me your dream branch in the comment section below, just for so that I can address you in the future with those names. Okay, because today you have promised in the comment section below, so you started working on it as if you are manifesting it today in 2025 December, when you are with me at the G Bhanu Prakash Medical Academy channel for the remarkable repetition 2.0 for the subject of psychiatry. The causes of delirium: obviously you'll have infection, metabolic disturbances, and withdrawal features. You can land up in the delirium. So this all can land up in the delirium, and this slide has been taken so that you know why does a delirium happen. Okay, PETS and cardio. PETS is a good branch. PETS is a really good branch. And cardio. After MD medicine, you are doing a DM cardio. Pratyush Varal. Remember your name. We have manifested it today. I'm waiting for other people to manifest as well. Okay. So now treatment with haloperidol, buffering, orthopedics, genetics. Okay. Good. I wish you get all those branches. I wish you get all those branches and manifesting at this channel. And do let me know when you get those branches. But how will you contact me? On the right to right, the left on Instagram, Dr. Tilak Dixit. Okay, available for your service. Tanya Firdos for the North Side preparation. All the best. Tanya Firdos for the North Side preparation. And all the best. All these peoples having PEDS, cardio, orthopedics, genetics, and one of them is unsure. Okay, you'll get your shot ready as soon as you go about when you are doing your internships and everything. You'll be sure enough, and sometimes it's the inner calling which we are waiting for. Sometimes you'll get the calling from inside that I want to do this and I want to do that. And remember, whatever branch you're selecting, no branch is good, no branch is bad. Everything is helping people to get better, and you guys are helping uh, it to be better. Okay, so on that note, treated with haloperidol and atypical antipsychotics. Just give me a second. Just give me a second. Okay, so we're back. No. Okay. Okay. Treated with haloperidol and a typical antipsychotic, avoid benzodiazepine except in alcohol withdrawal. Now coming to the dementia part. Coming to the dementia part, progressive cognitive decline, usually irreversible. Now this is irreversible. Now you give drug, ample amount of drug and everything, but still it is not reversible because happening in the subjective space called as brain. Okay, so developing subprotein problems leading to the dementia old age problem, and most common of this is Alzheimer disease, the top proteins and the neurofibrillatory tangles. Now coming up, another question, very important, another question, but before that we'll have a short amount of break and we'll return in the session as soon as possible. You guys can take up water and coffee, and we'll resume from this slide, which is known as the Alzheimer disease. Okay, we're having a short break. Okay. ओके, मेरे दोस्तों, मेरे मित्रों, आ चुके हो सब? Everybody here? Just waiting for you guys to come back again in the live chat. Waiting for you guys to come back. Okay, my friends have already come up in the chat. Okay, so many sessions have been done in the past on this channel for the remarkable rapid revision 2.0, and it's really going awesome. And I've personally watched many of the sessions, and they've been absolutely brilliant session. Mr. Puneet Bhojani sir have done an awesome session. Shashwat Ray sir have done an awesome session, and many faculties have done session. P. Jambal sir's session is upcoming right away in the schedule also, and it's going really good. Trust me, guys, if you're following these sessions and you're making sure that your preparation is going good, sometimes in during the session we feel that we have not studied enough, we don't know the subject, and that's why we have that's the whole motive of bringing these sessions to you guys, so that you can sum up all your, the one who have read everything might sum up all the things, the one who is read something or the other but not really sure about the subject may get a lot of information. And for someone who has never ever really studied the subject really correctly but has a willingness to pass the examination, also come up in the session and remarkably rapidly revise all the session. Now coming up to the session, as my friends are coming up in the play chat, they are already here, my friends are already here, so we are starting with a point where we left. If somebody has lost that where we left over dementia and delirium, and after that the laptop was discharging, that's why we took a little bit break for our side. And now we're coming to Alzheimer's disease. You know, it is a memory loss condition, it is a anomia situation. Okay, so it is a memory loss condition, it is an anomia situation, it is impaired daily activities, and acetylcholine inhibitors may slow down the progression of your Alzheimer's disease. So, my friends will now write in the comment section below so that I can mark their attendance whether they are present or not. What are the acetylcholine inhibitors, ACH inhibitors, being used in the Alzheimer's disease, starting with the T and P? I'm given a small hint and I'll drop this hint again because you guys are clever at picking up hints. So, my friends will answer in the comment section below what is the acetylcholine inhibitor being used in the treatment of Alzheimer's disease. Is it starting with T or P? Meanwhile, you answer, we will come up again with Lewy body dementia. Dementia with the visual hallucination and Parkinsonism, fluctuating alertness. It is just similar to the Parkinsonism. Donzepil. Okay. And I'm asking about acetylcholine inhibitors. What else? Something having T in it. Okay. Lewy body dementia is a dementia with a visual disturbance and Parkinsonism, fluctuating alertness. Now, this you already know. Examiner is not now framing questions on Parkinsonism and Lewy body dementia. They are framing more questions on the vascular dementia because it is a stepwise cognitive decline post stroke. Okay, so how will they frame the scenario that this person developed stroke because there was an artery that got blocked here and developed stroke, and it is having a step by step decline. First it has a features of bowel difficulty, then led to the urination difficulty, then the motor difficulty, and now he's not able to recognize people. Okay, so this is stepwise cognitive decline seen in the vascular dementia. Still waiting for my friends to answer what are the acetylcholine inhibitors used in the treatment of Alzheimer's. Okay, one has answered on the pill. I'm waiting for others to answer. Tick's disease, early personality slash behavior change, frontotemporal atrophy. Okay, so there is a frontotemporal atrophy, and that leads to the early personality change and the behavioral change. Okay, so this person handpicks his own problem because there is a frontotemporal atrophy, which is seen in this case. Now, cluster A, it's odd and eccentric, and cluster B is dramatic and emotional. Okay, and cluster C is anxious, fearful. So these are the grouped clusters. Okay, cluster O is sorry, cluster A is eccentric, eccentric. Okay, Riva stigmine patch. Are you sure? Are you sure? Reverse stigmine patch. And also tell me, what is the FDA approved drug for the treatment of Alzheimer? FDA for Alzheimer's. Very, very important. Trying to share an image if it comes up in this iPad. I'm trying to share. But meanwhile, I'll write it down there so that you don't feel. Now, what is the FDA role in providing Alzheimer's disease treatment? It is Leqembi, which is being used. It progression, slows the progression, and this is the drug which is now FDA approved. Coming to the acetylcholine in Alzheimer's, the drugs which is being used in this condition is very, very important. I hope you are able to follow these things. Leqembi is a recent FDA approval, and that can come up as your question into the examination. Coming to my friend who said don't pezil and rivastigmine, that is also used along with galantamine. Okay, they block the acetylcholine enzyme. This is ACH inhibitor. Okay, and that slows the progression in Alzheimer's disease. I hope it is clear now for everyone. Trying to share up the image. If it comes up, I'll show you as soon as the session progresses. Okay, so my friend Riva streaming patch. Priya is good answer. Tonsibil Prem Kishore. I was looking for someone to answer galantamine. Okay, okay. So done and dusted with these two parts. Cluster A is eccentric, cluster B is more dramatic, dramatic, and cluster C is always worried. Why it is happening? Where it is happening? Whom it is happening? Is it not me? Is it him? Is it her? Is it her? Is it haunting? Is it not haunting? It's fearful. It's fearful. Okay. So these three are really, really important. Okay. Always worried. Okay, how will be the exam going? What will be the questions coming? I have not prepared it well. It's cluster C. Don't be C. Don't be A. Don't be B. Only be a star who answers the question correctly, because you are the doctor visiting the patient into the OPD and not for the exam purpose. Okay, so you know at least one important thing about the feature, so that you know that this you're dealing with this particular case, and that's what the examiner wants to know, whether you have studied enough to classify the case into the diseases and the treatment that you know about the diseases. And life is very long. You can learn in life many times. Many approvals will come, many new FDA drugs will come. You will add up your information for the basic bricks that you have to develop has been assessed by the examiner in NEET PG also, and for the FMGE also. For those guys who are preparing for FMG, you have a targeted advantage in the NEET PG when you go about this session. Please watch this session multiple times because it is easy, but it is repetitive, and it can come up as it is in the examination. Coming to the paranoid, knowing the concept of the paranoid is a distrustful person and a suspicious. You already know it is a suspicious person, always doubting on the other person, but it is actually a distrustful person also, not developing trust on anyone. Okay, some of my friends have written suspicion, mistrust, doubtful. Most common late onset is good prognosis. Arjun Patel, very nice answer. Arav, very nice answer. Pain Kishore writes Mementin. Okay, okay. So hats off to you guys for a beautiful knowledge, and congratulations because you are going to excel up into the examination. Okay, guys are really good at it, and I want other guys to answer as well. MD Sajid X1Z8E. Hello, sir. Hello, Sajid. Okay. Okay. ठीक है. Now, packed food always prefer this kind of a person. Suspicious person, packed food, distrustful. Okay. Schizoid personality, a word that is similar to the schizophrenia. Schizoid, that means anything where we write oid in, like it is carcinoid, tumoroid. So it is just like that, but not exactly that. So it is a socially detached person that prefers solitude, just like us. Okay, just like us, you and me. So we are socially detached because we are preparing for the examination and we prefer solitude. अब इसी शांति में हमें मजा आता है. ठीक है, तो we prefer solitude. So we are not schizoid basically, but schizoid person is having these kind of a traits. So not exactly what I mean to say is that it is not exactly schizophrenia, it's not exactly schizotypal, it's not exactly schizoaffective. It's schizoid because it is detached and it preferred solitude. Okay, not having other features. Okay, can't make relationships. रिलेशनशिप पे बात आ जाती है तो फिर क्या ही बोले. सौम्या शेख, we can't say anything about relationship because our friends will go into the PTSD and flashbacks that I don't want. Okay, but still, on a lighter note, antisocial personality, as you know, disregards for the right of the others and may lie or steal objects. Okay, classical example of the antisocial personality they will give you that a person is violating rules, is not following commands, and it's destroying the garden chairs, or it is destroying the lamps in the gardens. Okay, so that is kind of a personality is known as the antisocial personality. Coming to the borderline personality, inability in the relationships. Who's saying this? Inability in the relationship. Someone wrote it. Okay. Inability. Oh no. You have, maybe you have removed the comment. Why? Not needed. Okay. I was just joking around. Inability in the relationships, self image, impulsivity, and recurrent suicidal behavior. This is seen in the borderline personality disorder, and that is different from the antisocial personality disorder. Antisocial is breaking all the laws and things, but borderline personality is not being able to stabilize a relationship, has a self-image problem, very impulsive, recurrent suicidal behaviors. Some of the traits you can also find in the Kabir Singh movie. Okay. Borderline personality disorder requires a psychotherapy. Very good. Histrionic personality, an old question which was coming up in the examination, may repeat nowadays. Excessive emotionality. Okay, attention seeking. Now, all my friends, do tell me, have you heard about a PF test? That is personality factor test, in which a second parameter is of the emotions. So, if you're on this, if this is the center scale and this is the negative part and this is the positive part, you have to lie somewhere here, but there is some person who is just lying close to this line or close to this part or maybe here. Okay, so these are the person who are excessive emotional, they are very very emotional, you know. And if it is combined with attention taking problem, they become a histrionic personality. That's why I'm explaining you so much, because this can come up as a scenario based question. So are you guys able to follow? Please write it down in the comment section below. That are you guys able to follow this session? Is this session helping you out in some or the other ways? Do let me, do share your feedback, and do tell me that how are you going about in this session. So is this session teaching you new things that you already know, or we are building concepts that now you have mentioned someone in the comment. I can't take their name, but my smile is enough to understand. Narcissistic personalities also. Okay. Narcissistic, coming to Priya's comment, narcissistic personality, that is grandiosity and the lack of empathy. ठीक है, ये किसी को नहीं समझते हैं इनसे बेहतर. ये होता है नार्सिसिस्टिक पर्सनालिटी. मैं ही बड़ा हूं, मैं ही सर्वशक्तिमान हूं, मैं ही सबसे बड़ा हूं, अपुनेज भगवान है. ठीक है, सेल्फ लव. ठीक, अवॉइडेंट पर्सनालिटी, another example of social inhibited, hypersensitivity to criticism. This is all the aspirants. Basically, just like us, we are hypersensitivity to criticisms. कि हमें क्रिटिसाइज कैसे कर दिया उसने, कि हमें बस एक माइक्रो का एक ऑर्गेनिज्म ही तो नहीं आया था, हमें सिस्टोसोमिया ही तो बोलना नहीं आया था, इतना क्रिटिसाइज करने की कहाँ जरूरत थी मुझे, कि मैं पढ़ता नहीं हूँ, मैं आवारागर्दी करता रहता हूँ, मैं शॉर्ट सब्जेक्ट्स पढ़ता रहता हूँ, मैंने माइक्रो नहीं पढ़ा, इतना क्रिटिसाइज करने की जरूरत नहीं थी, मैं बात ही नहीं करूंगा, मैं चाहूंगा ही नहीं, ठीक है, मैं अवॉइड करूंगा, ठीक है, I'll become a avoidant personality, and that's what I don't want you. You have to be open about the criticisms. Criticisms will come and go just like crest and the trough of life, and the stairs that go up and the stairs that go come down. They're just like that. They'll happen. That occurs like a wave, comes up like a wave, and goes like a wave. Criticism will come and go. People will criticize you for your choices of FMG, NEET PG, and everything. But what you have to believe is in yourself, and because your teachers are believing in you. So we are bringing you best of the session so that you excel in your career, and we are working on countless hours just to bring you better content so that you'll end up in a better situation and thank us later on. Okay, so on that note, dependents, who are the dependents? This has already been asked in this PSM session. Okay, needs to be taken care of and submissive. So examiner will give you a word, there is a submissive person. So exactly what do a person submissive means, that he is a dependent. Coming to the, this is just for your concept, when the examiner is writing submissive, that he means to say that the person is dependent. Okay, so now Raj Patel has shown a thumbs up with 100 that he is able to follow the session, and thank you so much, Raj, and the others. Also, please do share it with your friends so that they also land up in the world of psychiatry along with Dr. Tilak Dixit. Obsessive compulsiveness is a preoccupation with the orderliness and perfectionism, like many of your friends whom you are staying together likes to clean up the room every now and then, and they don't want that the pen should be kept like this or this or this. They have to be in a perfect order, one after the other, in a perfect way. The books are balanced in a perfect way, the wardrobes are arranged. So working on orderliness and perfectiveness makes them obsessive and compulsive, not really a disorder. That's what I want to say. Not every obsessive compulsive person is having a OCD problem. D is missing in that case. Okay, D only comes when it's hampering his or her life. Now, sexual disorder, coming to the sexual disorders, premature ejaculation. Now, this is treated with SSRI, behavioral techniques. My friends will now write in the comment section below, what techniques are we talking about? Are we talking about some squeeze technique? Somebody in your side know the name of that squeeze technique? You write in the comment section below. I'll be waiting for your answers to come. I'm talking about the premature ejaculation sub technique, which is known as the squeeze technique. What is the full name of that squeeze technique, and which is the other uh, thing that we are used for the premature ejaculation as a part of the therapy? Write in the comment section below. I'll be waiting for your answers to come up. Okay, coming to the erectile dysfunction, this can be ruled out medical causes, and sildenafil may have. Now coming to the famous ADR of the sildenafil, it is developing a hypotension. Is developing a hypertension. And my personal opinion, I've seen a case like this who has taken a sildenafil at some circumstances and later on presented in the emergency department with a 90 by 60 BP and was feeling dizziness and headedness and felt that something of the bad has happened with him or her. And we've taken ECG and we found out that it's a hypertension and bradycardia as well. Okay, so that kind of person sometimes land up in your emergency department. Some of you guys might take up the anesthesia, some of you guys will take up the emergency medicines, and you will land up in cases like this, and you'll remember that we have been taught in the subject of psychiatry by Dr. Tilak Dixit. Coming to gender dysphoria, we had already talked about body dysmorphia, and now we are coming to the gender dysphoria. Now, my friends have answered. Sildenafil never given with NTG. Very good, Aram. You've already given the answer that it leads to the hypotension. With nitrates, they are contraindicated. Okay. Isha Chen has also rightly answered. Aram has also mentioned that it causes vasodilation. That's why it leads to the hypertension and cannot be given with the NTG. So, Master Johnson's technique. Okay, I'll add up to this. Which squeeze technique I was talking about was Siemens squeeze technique. Siemens squeeze technique. It's not Siemens, it's Siemens squeeze technique. Okay. So I was talking about that squeeze technique that can be used in the premature ejaculation just before the orgasmic phase. The uh, penile part has been squeezed so that it doesn't land up in the premature ejaculation, and that's what where the NEET PG framed a question. Why I'd asked you is not for fun. I'd ask you because the NEET PG has framed question out this part, that which technique has been used, and second time they framed question like this, that why this technique helps. Okay, because we are having a premature ejaculation in certain phase. So that is which phase? That is orgasmic phase, and that's in this phase it helps. That's why it is very, very important. I hope I have clarified you with the answer. Okay, coming to the gender dysphoria, distress due to mismatch between the gender identity. Okay, so a person who is a boy doesn't feel comfortable in a boy's attire or in a boy's body, and has to be is constantly feeling that he is to change his gender. So there is a mismatch between the gender identity and the assigned sex. He feels that he's a female from inside and his body is a male. Okay, so that difference is not being tolerated, and that is gender dysphoria, and we have to keep good empathy for these cases. We have to understand these cases, and psychiatry teaches us the art of understanding things. Okay, it's not about treating the person with a mental illness, it's the art of understanding the things. Although we are also treating mental illness and their associated issues, according to the Mental Health Act, we are also addressing their issues. But we have to provide a good empathetic conversation. We should be able to listen those conversations. Coming to the paraphilic disorders, okay? Paraphilic disorders already may be covered in the FMT, so not really going in the depth of it. Unusual sexual interest causing the distress and impairments. Okay, ECTs are used for refractory depression, suicide, and catatonia. We've already mentioned this as in the above part of the session. Common antidepressants which you are using is SSRI, SNRI, tricyclic antidepressants like amitriptyline. So they are constantly framing questions on amitriptyline and MAO inhibitors, also on the cheese reaction. Okay, so these are the three parts they are framing questions. Cheese reaction. Okay, so they're forming questions on amitriptyline. Amitriptyline is an example of what kind of a drug. That's why they want to ask you the classification of the drug, which is also important, but I'm not taking too much of tables. Otherwise, it will become very bothersome for you guys to handle. Okay, cheese reaction, hypertensive crisis, cheese reaction, drug of choice is phentolamine. Before even I had written this, my friends have already written it. You guys are really, really awesome, preparing so well for the examination. I am so much happy for you guys because you've already known these things. So I need not to explain it too much. But I was about to say that phentolamine is the drug of choice for the cheese reaction. Okay, phentolamine. Okay, now, coming up to the tricyclic overdose. If you take a tricyclic overdose, what will happen? You might land up in the coma, convulsions, cardiotoxicity, and the ECG needs to be monitored in those cases. Coming to the SSRI side effects now. This is really, really important because very now and then we are using SSRI. So it can lead to GI upset. Okay, no problem. Sexual dysfunction and serotonin syndrome. These are the two things we need to remember as it is, because this might come up in the next examination. SSRI is very frequently used, but what it leads to GI upset, then sexual dysfunction, and then serotonin disorder. Coming to the sodium bicarbonate is a drug choice for the toxicity. Okay. It works on the principle of alkalizing the urine. Okay. Presynaptic neuron and increase the level of serotonin. Okay. SSRI side effects have been discussed in the comment section also, and these guys are writing it brilliantly. Okay, so the two ADR that you need to follow is sexual dysfunction and serotonin syndromes. ओके, यहाँ पे नौशिया वोमिटिंग डायरिया नहीं बोलना है, ठीक है, हर जगह वो नहीं बोलना रहता है। चलिए आगे बढ़ते हैं। एंटी साइकोटिक साइड इफेक्ट्स क्या होते हैं? एक्स्ट्रा पिरामिडल साइड इफेक्ट। अगर मैं इस चीज को बॉक्स में डाल दूं, इफ आई पुट इन अ बॉक्स एंड राइट इट, 100% ऑफ चांस ऑफ आस्किंग द एग्जामिनेशन। ऑल गाइस concentrate on this point. Anhedonia is also another important side effect. Coming to the EPS, extra pyramidal side effects, acute dystonia. Okay, person who's taking drugs and later on developing a spasmodic dystonia on the hands. So acute dystonia, okay, or developed a staggering gait, Parkinsonism like features, okay, or developing a tardive dyskinesia. Okay, these all are extrapyramidal side effects of the antipsychotic drugs. Akasthesia. Coming to the akasthesia, it's a terminology based question might come up. For the akasthesia, it is a restlessness treated with propranolol. Okay, basically the person is restless, the foots are moving like this. It's not tremor, it's restlessness. Okay, akasthesia, can't stay at one place, restless, and treated with propranolol. That is the drug of choice for akasthesia. It starts somewhere. My friend has written that the stream has been stuck. So are you guys able to see me? Are you guys able to hear me? Please write yes in the comment section below if you guys are able to see me. It's okay. Okay. Chili. Priya ji ne keh diya, it's okay. So it's okay. Neuroleptic malignant syndrome. Another important question that can come up in the examination as it is. तो जिसको हम ऑड क्वेश्चन बोलते हैं साइकेट्री में, हम उसको डिस्कस करें। इसमें क्या होता है? फीवर होता है, इट्स रिजिडिटी, कंफ्यूजन, एंड वी हैव टू स्टॉप द antipsychotic treatment and treat with dantrolene sodium. Now, dantrolene sodium. Okay. Dandelion. Okay. Very good. Very good. Very good. Very good. Claps for you guys. Answering so beautifully. Tanya, Raj Patel, Isha, Arav, Tanya, Anil Pan, every one of you. Priya, good, 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 good. Congratulations. Doing it really well. Also, other guys, you also come up in the comment section below and answer these questions. Now, neuroleptic malignant syndrome comes up with a fever, rigidity, confusion. Only condition when we are stopping the antipsychotics, apart from the fact that they might lead up to the allergic reactions and everything. But the main clinical feature, neuroleptic malignant syndrome, and this is an answer of exclusion when it comes up into the examination. Coming to the sleep disorders that everyone is feeling right now, insomnia, narcolepsy, sleep apnea, REM, parasomnias. Apart from this, sleepwalking is very, very important, and night terrors, because it occurs in the NREM sleep, non-rapid eye movement sleep. Okay, there's a rapid eye movement sleep, and then there is a non-rapid eye movement sleep. That is why you don't have a core memory about it. Okay, so you can learn that this in the movies we see a person is sleeping and suddenly starts to sleepwalk, and when being asked the next day, he says that I don't know why I was walking. Okay, you told me that I was walking, I don't know. So sleepwalking doesn't have memory because the eyes are not moving, so they don't have a memory. So it's happening in the non-REM sleep. Also the night terrors जो हमें सुबह तक याद नहीं रहते हैं। चलिए, coming up to the REM sleep. Okay, coming up to the REM sleep. Brain is active, body is paralyzed, and there is a rapid eye movement. Okay, so REM sleep ki characteristic we should know. REM sleep characteristic we should know that brain is active, eyes are moving, and but the body is paralyzed. Okay, he's still not moving. That's why it's sleeping. Okay, so the REM sleep, body paralysis, is seen in the REM sleep. Okay, coming up to the mental status examination, also known as the mini mental status examination. Okay, assess the appearance, behavior, speech, mood, thought, cognition, insight, and judgment. After all these tabulations, we come up with a numerical value that is less than 25, more than 25, 20, 30, and then we do a mental status examination that this person is having this part, and this helps us in the treatment protocols of the patient. Coming to the EEG, many of you guys have been working in the hospital and saw already seen the EEG. So it is normal in the psychiatric illness except for delirium, in which the waves are slow. As for example, in certain person, the EEG waves are coming like this, beta, alpha, and everything. But for the delirium, it's showing no or slow waves. That shows that the person is having a cloudy amount of consciousness. Okay, so the consciousness. Mm, okay, MMSC and MSC are different. Isha Jain is asking this question. So MMSC is a short portion of the mental status examination. Actually, the mental status examination was a good big part, and then it has been reduced to certain points which are effective and good. So now it is known as mini mental status examination. So it is a smaller, compact, concise version of the mental status examination. 23 to 30 is a normal score, very good. Somnambulism has been mentioned as a part of the sleep and increased CPK in where? Skeletal muscle relaxant. Okay, got it. You were telling about the narcoleptic malignant syndrome. Everybody is answering really, really good. And hats off to your knowledge. Impulse disorders. Okay, kleptomania. This person likes to steal objects. Pyromania, set things on fire, as you will be setting stage on fire when you are going for the examination. Trichotillomania is for the hair pulling. And when I say setting stage on the fire, that means performing really, really nice, not actually firing it up. Okay. बाद में मत बोलना सर ने कहा था ठीक है कंडीशनिंग सो this comes up in the physiology. The classical model was given by Pavlov, and the operant model was given by the Skinner. Okay, so this part has been constantly ignored by the students. That's why I have mentioned it here. The operant model was given by the Skinner, and the classical model of the conditioning was given by Pavlov. By the way, Pavlov sir was a favorite question of the examiner back then. Okay, now coming up to the defense mechanism, as we all do, we deny the things, we project on somebody else, we prove that we were not wrong, we go out from the paces, and we sometimes do a sublimation also. Okay, so this and structural theory of mind was given by Sigmund Freud, sir. That is id, ego, and superego. These three were given by Sigmund Freud, sir. Now, intelligence test IQ, which is less than 70. Now, this is really, really important. IQ is less than 70 is intellectual disability. Now, the word which has been changed in the Mental Health Act is the intellectual disability. Okay, so they have changed up the word to intellectual disability and not mental disease. That's why I've written this very, very important line. This can come up as a recent advance. Now, psychiatry deals with the diagnosis, treatment, prevention of mental, emotional and behavioral disorder. सर पूरे सेशन के बाद आप साइकेट्री किससे डील करती है ये क्यों बता रहे हैं? Why are we discussing this? Because the examiner is asking component questions in the past. Okay, so my friends have written, Arav has written, it is a pleasure principle, ego is reality, and super ego is moral principles. Very good. Your concepts are really good, Mr. Arav, and you're performing really well, along with Tanya Firdos, Isha, Arav, Priya, Anil, and Raj Patel. Every one of you is performing really, really nice. Okay, so we are now talking about we are diagnosing a patient based on the clinical features we know and the diseases we know and the PVAQs we have learned. We are treating them with the first line drugs, second line therapies, and third line ECT on and off when required. Prevention of mental, emotional, and behavioral disorders. That's why we are treating up with the CBT. So our concept should be clear why actually what we are doing and why we are doing. Okay, so this definition itself tells us this definition itself tells us that how to proceed when we are learning the subject of psychiatry. This orient us to the orientation of the subject for the exam purpose. Okay, sorry for the throat. Delirium is transient, reversible, acute confusional state. The part where we left when we were going for the break. Okay, so it's a transient, reversible, acute confusional state, often characterized by fluctuating level of consciousness, also known as the cloudy consciousness. Okay? Now, delirium tremens is the most severe form of alcohol withdrawal. Treatment of choice is benzodiazepine. Hallucinations have been seen in the delirium tremens. Okay. Dementia refers to the progressive decline in the cognitive function, most commonly due to the Alzheimer's disease. We've already discussed this. Alzheimer dementia is characterized by beta amyloid plaques and neurofibrillatory tangles in the brain. And these two are the important features of Alzheimer dementia. Let me clarify you on this point that beta amyloid plaques have been visualized in brain samples of the Alzheimer dementia and beta amyloid के लिए हम कौन सा stain use करते हैं? Congo red stain, which gives a apple green birefringence when it is seen in the histopathology slides. For the beta amyloid deposition and neurofibrillatory tangles are seen in between the neuronal cell, and these two are the characteristic features of the Alzheimer dementia. Drug of choice: atypical antipsychotics, risperidone. And as we have discussed, acetylcholine inhibitor, ronzafil, rivastigmine, and galantamine. Schizophrenia, again revising this part. Schizophrenia is a chronic psychiatric disorder with symptom lasting more than 6 months, like delusion, hallucination, and disorganized thought. One, two, and three. Very, very important. Okay. First line symptoms we have already discussed. First line treatment we've discussed. Clozapine we have discussed. Okay, delusional disorder, we have already discussed. It is more than 1 month of a false, fixed, firm belief without schizophrenia symptoms or without change to contrary belief. Okay, so these a few points which we have taken right now from the schizophrenia to this part, we've already discussed it. Still, if I missed it, first time symptoms is the auditory hallucination, thought broadcast, thought insertion, and passive phenomena. First line treatment of schizophrenia is atypical antipsychotics like risperidone and olanzapine. We've also discussed that the clozapine leads to the was used for the resistant schizophrenia and leads to the common complications like granulocytosis. Cytosis. Okay. So already discussed us. Coming to the brief psychotic disorder, psychosis lasts for less than 1 month and often stress related. Okay, change of job, change of place, and everything. Okay, we've also seen this. Hallucinations are what? Are false perceptions in the absence of the stimulus. Stimulus is not there. Most common type is auditory. Like no one is there in the room and you are hearing voices of someone that's not even there. Okay, so it's a false perception and the stimulus is absent. Okay, for the illusion, it is a misinterpretation of the real external stimulus. That means myocarditis and a granulocytosis, very nicely written by Altruistic Soul. What a beautiful name. Altruistic Soul W7Q. Good name. Good name. Okay. Illusions are misperception of the real external stimulus. The classical example that everybody talks about, rope being mistaken for a snake, rope being mistaken for a snake in the night is illusion. Okay, so stimulus is there for the illusion, for the hallucination, it is not there. Mood perception without stimulus is hallucination. Okay, mood disorder include depressive, bipolar 1 and bipolar 2. Bipolar 1 we know mania and depression. Bipolar 2 we know hypomania and depression. Hypomania and depression. Hypomania and depression. Well, this line is really, really important. Okay, we have already studied this image in the starting of session, just revising that part. Okay, so it's mostly coming back again. Just push, we just push. Just push. Okay. Coming to the, so these all part we have already taken. Still, if you guys want to revise in 5 minutes, that's why I've written it again and again, so that we can revise it in simple time, so that you don't have a FOMO now. So major depressive disorder stays for at least 2 weeks. 2 weeks is important. Anhedonia, previously pleasurable activities, mood and impaired functioning. ठीक है. First line treatment for depression is SSRI, sertraline and fluoxetine. Electroconvulsion therapy is only given when suicidal ideation, catatonia, psychotic symptom, severe depression, plus food नहीं ले रहा है, plus drugs not taking, and recurrent suicidal tendency. That is why only ECT is required, and as we have discussed, ECT is given 0.6 second. Bipolar हो गया. ड्रग ऑफ चॉइस फॉर एक्यूट मेनिया इज लिथियम और वेलप्रोइड. थेरेप्यूटिक डोज मॉनिटरिंग करनी पड़ती है, और 4 से ज्यादा अगर हुआ तो वो लिथियम लिथियम टॉक्सिसिटी कर सकता है. Done. Lithium is contraindicated in the pregnancy and kidney disease. Cyclothymia. Cyclothymia के लिए हमने क्या याद किया था? साइकिल की तरह चलता है. 2 years of fluctuating mild depressive and hypomanic symptom without meeting the criteria of major depressive disorder of mania. या मेजर डिप्रेसिव डिसऑर्डर नहीं होगा, मेनिया नहीं होगा, पर फ्लक्चुएटिंग माइल्ड डिप्रेसिव हाइपोमेनिक सिम्टम्स आएंगे. दैट इज साइक्लोथाइमिया. Just quickly revising the facts we have already learned, so that this session becomes a wholesome for you guys, so that you guys can come up, after watching these 2 hours, you come up with some beautiful crafted one liners that will help you revise the subject in a more effective manner. Abnormally elevated, expansive, irritable mood lasting for more than 1 week is known as your mania. What exactly we call as mania? Elevated mood, that is expansive, out of the was thinking, irritable, and more than 1 weeks with impaired functioning. That is most important. Okay, function is impaired. This can happen with anyone. For 1 week also, person can be irritable, expensive, elevated mood, but if it is hampering the function, then it is known as the mania. Hypomania, similar to mania but less severe and lasting for only more than 4 days without major impairment. That's why it is a subtle form of mania. That's why it is hypomania. Persistent depressive disorder, dysthymia, and dysthymia last for the more than 2 years. That is important. Dysthymia, cyclothymia is very, very important. This time the depressive symptom is more than 2 years. This time the depression is staying for more than 2 years. Why? बार मैं आपको repeat करूँ. This time it is staying for more than 2 years. That is why it is known as the dysthymia. Okay. चलिए. Coming to the postpartum blues and the postpartum depression. Very, very important. Postpartum blues is a transient mood fluctuation after the childbirth, and it resolves within 2 weeks. Okay, 2 weeks में resolve हो गया. On the contrary, postpartum depression is a severe depressive disorder within 1 month of delivery with tendency tendency to harm the child. Harm the child. In this case, treatment is needed. In this case, no treatment is needed, only the counseling part. And this is fairly more common in occurrence in the general public. The postpartum blues, mood fluctuations are there, resolves within 2 weeks. Okay, postpartum depression has to be treated. Okay, reassurance, very good. Postpartum psychosis is also there. It begins within 2 weeks after postpartum. Psychiatric emergency, very, very important, and requires hospitalization. Postpartum psychosis. Psychosis is way ahead from the depression, and it is still bigger than the blues. Blues is just a transient phenomenon where the depression needs to be treated. 1 month is the characteristic for the postpartum depression. For the postpartum psychosis, it begins within a very less time, that is 2 weeks, and it is a psychiatric emergency. In the psychiatric subject, still you have emergencies. Emergencies are everywhere. Obsessive compulsive disorder, we already know that what are obsessions and what are compulsions. Thoughts are the obsessions for all those guys who have not learned it in the session, and repeated behaviors are known as the compulsions. Okay. First line treatment for OCD is SSRI, and the second line is clomipramine. Okay. Augmentation with the antipsychotics for severe refractory OCD is risperidone, aripiprazole, haloperidol, and olanzapine. Now, these four drugs you have to remember as it is. Now, write it with me: risperidone, aripiprazole, haloperidol, and olanzapine, which are augmentation of antipsychotics for the severe refractory OCD. Very, very important. Now, coming to the cognitive behavior therapy for the OCD and many anxiety disorders, this CBT is used. Panic disorder, we've already done. Panic disorder, okay, phobias, we know. Just revising it again. Just revising it again. Panic disorder is a recurrent, unexpected panic attacks. Worry of the future. रिजल्ट कैसा आएगा, कैसा एग्जाम होगा, वरी ऑफ द फ्यूचर, और उसको सोच सोच के पैनिक करना. तो दैट इज नोन एज द रिकरेंट पैनिक अटैक्स. आ जाए, परसों आए, तरसों आए, 3 दिन बाद आए, 5 दिन बाद आए, एग्जाम के 1 दिन पहले आए, बहुत सारे अटैक्स हो गए. सो दैट इज नोन एज द पैनिक डिसऑर्डर. एंड व्हाट थिंग is required when we see panic word is the word impending doom, which have already been written by one of our friends, Anil Pant. Okay, drug of choice for panic disorder is SSRI. Phobias. Irrational word is important when we are talking about phobias, irrational fears of the specific objects or situations. Okay, treatment is graded exposure for the severe phobia, generalized anxiety disorder. This I was about to tell you again. You have to clear this point. Excessive worry for more than 6 months and multiple topics. Okay, more than 6 months and multiple topics is generalized anxiety disorder. Now, first line is SSRI in psychotherapy. You already know it. Crisis intervention is immediate, short term psychotherapy help during the acute psychological stress. And this, my dear friend, may come up in your exam as a question. Guys, please focus on the crisis intervention. It is an immediate short term psychotherapeutic. एक ऐसी चीज जो अभी कभी दे सकते हैं, शॉर्ट टर्म में काम करेगी और एक्यूट साइकोलॉजिकल डिस्ट्रेस में काम करेगी, अभी 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 इसी वक्त काम करेगी और एक्यूट फेज में काम करेगी और शॉर्ट टर्म रहेगी, उसको क्राइसिस इंटरवेंशन बोला जाता है. चलिए, पीटीएसडी हमने पढ़ लिया था. इट्स ऑलरेडी फॉर दी 1 मंथ. एक्यूट स्ट्रेस रिएक्शन इज लेस देन 1 मंथ, और ये दोनों डिफरेंट होते हैं. मोर देन 1 मंथ इन पीटीएसडी, और नीचे वाला एक्यूट स्ट्रेस रिएक्शन इज लेस देन 1 मंथ. ग्रेजुअल एक्सपोजर और सिस्टमिक डिसेंसिटाइजेशन. ठीक है. सोमैटिक फॉर्म डिसऑर्डर हमने पढ़ा था, मल्टीपल सिस्टम में होता है. सोमैटिक फॉर्म मल्टीपल सिस्टम्स में होता है. कन्वर्जन डिसऑर्डर में क्या अंतर है कि उसमें वीकनेस, सीजर्स, न्यूरोलॉजिकल सिम्टम्स दैट आर इनकम्पैटिबल विद द पैथोलॉजी. ठीक है. वो बोलेंगे कि हमें कोई न्यूरोलॉजिकल सिम्टम हो गया, देयर इज समथिंग वियर्ड इन माय ब्रेन, बट व्हेन यू चेक, देयर इज नो स्पासम, देयर इज नो ब्रेन power down muscle, everything is good. So it is conversion disorder. Factitious, we have already know the famous mnemonic. My friends will write in the comment section below. F for factitious, F for fame. He doesn't want money. Money. Malingering is for M. M for money. Malingering, one wants money. Okay. Dissociative identity disorder. Very, very important. DID. It is not dance India dance. Okay. It is more than two distinctive personality states, multiple personality disorder, just like our Bollywood movies. Dissociative identity disorder. Two distinct personalities. How many personalities? Three, four, five, six? No, it is more than two. Okay, it is not more than one, it's not more than three, it is more than two, and that can come up in your examination as a important question. Depersonalization. Now it's lost the reality and it is detached from self. I don't know why I'm staying in this body. I'm detached from my own body and my own reality. That is depersonalization, not realizing its true self. Okay, and derealization is unreality detachment from the surroundings. Okay, सेल्फ वर्ड आया तो पर्सनैलिटी आ गई, पर्सोनैलिटी, और अगर सराउंडिंग आ गया तो डी रियलाइजेशन, रियलाइजेशन. Okay, so what we are realizing is, so what we are realizing is our surrounding, and what we are thinking as a person is depersonalization. Okay, so definition of depersonalization and derealization is really, really important. Okay, so if you guys are able to follow this session, please do tell your feedback at the rate Dr. Tilak Dixit on Instagram, or by the name right to right underscore the left. Also, please mention your name, batch, your query, and feedback. I'll be happy to hear it from you how you guys felt the session. Please let me know in the comment sections how do you felt the session so far. Sleep disorders. Now, for the insomnia, short term, benzodiazepine like timanzipam and zolpidem, non-benzodiazepine. So the examiner is asking questions in the. So my friend said, okay, they are writing comments. Impending to gradual exposure, everybody is good at answering. Dissociative fugue is a new additive. Generate good Arav. And Raj Patel says it's a superb session. Thank you so much, Raj Patel, and everyone who is still there with us on this live session where we are reading psychiatry in a rapid revision manner. Okay, and a very different kind of manner that we have conventionally been reading. Now the examiner is asking questions on the zolpidem because अगर नींद नहीं आ रही है तो हम benzodiazepine दे देंगे. If the sleep is not there, if the sleep is not there, Jessica says it's a fascinating topic, very interesting. Thank you so much, Jessica, Raj Patel, and everyone who is there. Okay, so नींद नहीं आ रही है तो बेंजोडाइजेपिन दे देंगे like timanzipam, but zolpidem is the non benzodiazepine hypnotic which is being used in the insomnia. Okay, narcolepsy, narcolepsy, coming to the narcolepsy, has cataplexy, sleep paralysis, and hypnagogic hallucination. The drug which we are using is modafinil, modafinil. Okay, now just to summarize this, narcolepsy has cataplexy, having paralysis, but not hip, hypnagogic hallucination. Okay, so lepsy having plexy, having paralysis, hypnagogic hallucination, and is taking modafinil. Now, is it simple? Is it simple? Okay, so far we've read this line 100 times, but how to read it is all important. Lepsy, plexy, paralysis, hypnagogic hallucination, and modafinil treatment. Night terrors and sleepwalking occurs in the NREM stage. We already have learned this, but at which stage? That is stage 3 and the stage 4. Night terrors and sleepwalking. ठीक है? Volume कम कर, पप्पा जग जाएगा song. The person is walking in the night sleep, NREM state, no memory of it at all. Now, as a aspirant, we are constantly under either this condition or this condition. Okay, we always imagine us while we are reading this condition. Do let me know in the comment section below. Everybody has imagined themselves in this condition. Either we are restricting our diet to become underweight and we are totally concerned about our body image disturbance, or in the stress, in the few days of stress, we eat a lot and a lot and lot, and then we regret. But one thing we don't do is purging. Okay, with this patient is doing, that's why it is being kept under the name of bulimia nervosa, and one person who is Anorexic. So how do we write A? We write like this. So anorexic is a very thin person. Okay. And bulimia is a broad B-shaped person. That means it is a big binging big person. And जिसके पास कुछ होगा वही वॉमिट करके निकालेगा. So it is having a purging. So it is bringing things out, bringing out. Okay, bringing out big person, binging on food. Anorexia, thin person, underweight, body disturbances. Russell sign, very good. A huge clap. Okay, guys. BMI is less than 18.5. Soft criteria for the eating disorder. Superb, guys. Before I was able to tell you the soft criteria, my friend Anil Pant has already answered it in the comment section below. This guy is reading really nicely along with friends like Raj Patel, Jessica, Arav, uh, Priya, Tanya, and others are reading it so well. And I sincerely congratulate you on humble grounds that you are performing really, really good. Okay, coming to the bulimia nervosa, lab findings include hypokalemia and metabolic alkalosis. Why does it happen? Because he's vomiting out, he's getting all the potassium out, and because he's getting all the potassium out, sincerely he's getting all the potassium out, that's why it's landing into metabolic alkalosis. Okay, now what drugs we'll give to the bulimia person, a big person? Okay, so we will give him a fluoxetine. Okay, big person, simple drug, fluoxetine. Coming to the drug of choice for anorexia, जब bulimia की treatment हो गई, bulimia we have treated, so now we are treating anorexia. Anorexia, thin person has to be given psychotherapy, SSRI as an adjunct when it comes in the relapse. We are only giving drugs when the person is coming in relapse, not in the first ground. Okay, so psychotherapy is given on the first ground. Whereas in the bulimia, we start straight away starting with the fluoxetine. Okay, Russell sign is seen in both anorexia nervosa and bulimia nervosa, maximum chances in bulimia nervosa. Now, to my friends, I'll ask you a question. Now, on the side, I'll make sure that I make a face like this. This is the person. This is the person. Okay. Oh, no, no. Better. Okay. So, having folds over the head, and it's forming like this. So, what is this sign? If anybody of my friend would tell me, I'll be grateful. What is this sign seen in depression? This is regarding depression. Okay. No, it's not chipmunk. Very good, Anil Pant. Omega or very good sign. It's an omega, delta, Verukat are the signs we see in the depression. This one is the omega sign. Very good. Good, Arab and Anil Pant. Now, coming to the substance. Now, this is a different part. Okay. Now, coming to the substance disorder, impaired control, social impairment दिखता है, risk use, tolerance, withdrawal. Okay, this is just a generalized part. Alcohol withdrawal, the first line therapy is the benzodiazepine. Okay, withdrawing alcohol, the person is agitating, it's moving, it's fighting here and there and everywhere. So it's very agitated kind of a person. Give him benzodiazepine and let it sleep. Okay, disulfiram is used for the aversion therapy. We've already discussed it. Drug of choice for the opioid use is naloxone, IV or short acting. First of all, it is given IV and it is a short acting drug. Okay, very, very important. Opioid dependence. Now, a very, very important question. Opioid dependence, it is treated by methadone, buprenorphine, naltrexone. But what is the role of buprenorphine? It is used as a maintenance drug, and that's where the examiner is constantly putting question at this part. Which drug is used for the opioid dependence maintenance drug? That is buprenorphine. Maintenance is a big name, buprenorphine is a big name. Naltrexone is the acute, and methadone is also used for the acute cases. Coming to the drug of choice for the nicotine cessation, varenicline, buprenorphine, nicotine replacement therapy, we already know it. Cannabis intoxication, how does it present? Conjunctival injection, increased appetite. This guy eats a lot, talks in a euphoric state, and has no memory at all. This is cannabis intoxication. Our guys from our hostel look sometimes like this, the red eyes, ढेर सारा खाना, euphoric bateं, and no memory for the next day. Okay, have you guys seen these kinds of people in your hostel itself? Okay, so please write in the comment section below. Hallucinogen intoxication, like LSD, creates a perpetual changes, hallucination, and sympathetic symptom. Basically, it leads to a phenomena which is known as the flashback phenomena. Flashback phenomena. And what is exactly is flashback phenomena? It is having those triggering things which are already in the brain and bringing you the bad memories in front of you when you consume substance like LSD. And this is classically known as the acid trip. So the word acid trip and the flashback phenomena is associated with the LSD that leads to the perceptual change and hallucinations. Now, Wernicke's encephalopathy, the global confusion, ophthalmoplegia, and ataxia treated with imethymine. Korsakoff syndrome is irreversible memory loss, confabulations, and following Wernicke's Korsakoff. Wernicke's के बाद Korsakoff psychosis होता है. Now, word confabulation, so is basically to fill up those gaps. Person is creating story. So one part of the incident is going here, another part of incident is going here, but to bridge up the gap, it's creating a story to bridge the gaps. That is known as the confabulation or the memory gap, as Arav mentioned. Thank you so much. Personality disorder, A is eccentric. A is eccentric. B is dramatic. B is dramatic. We already have heard it. C is anxious. And who are anxious? We are anxious. As a person that is thinking continuously how the session will go. Session will teach us lot and lot things, but we are not able to comply. Sir, we are not able to apply it in exams. No, this will not happen. This will never happen. These are only the temptations has been guided to your mind, but this will never happen. Okay, so you will perform good, you will perform great. It's only the temptation of the mind. The mind already puts things in front of you that are unreal and irrational sometimes when it comes to the examination. That is why you'll have a self doubt, and that is why you'll prepare good. That is the defense mechanism the body is using against you. But don't fall in the trap. Believe in yourself, believe in the preparation, and continuously revise the one liners. There is no end to the revision. Let me tell you, there is no three revision, there is no four revision, there is no end to the revision. Mark my words, and do share me the feedback at the rate Dr. Tilak Dixit on the Instagram by the name of right to right underscore the and left. Okay? Do tell me your badge name and your concerns queries. I'll be waiting for your precious comments in the inbox. Now, whom do we call as a borderline personality? Who's unstable in relationship, has a self-image effect, and affect impulsivity and recurrent suicidal behavior. A person who is impulsive, just like Kabir Singh, has a self-image problem, and Kabir Singh had a unstable relation. So his mood was really bad many a times, although it didn't went to a recurrent suicidal behavior, but he had done one attempt in the movie. Okay, self-destructive, very good. So this is all in one sequence. Okay, so this is borderline personality disorder. Antisocial is breaking things in the garden. Okay, histrionic is excessive emotionality, and attention seeking. Very, very emotional person, histotonic. Okay. And attention seeking also. Narcissistic in grandiosity, needs admiration, and lacks empathy. This is very important. Lacks empathy. Okay. Doesn't think of anyone. He just needs his administration, appreciation all the time. Self love person. Okay. Anil Pant, MBT, DBT, psychotherapy. Good answers coming up from the comment sections. Okay. Avoidant personality, who is just like us, social inhibiting, fear of inadequacy, and hypersensitivity. And dependence need to be taken care. The word the examiner will use is submissive. Obsessive compulsive personality is preoccupation with the order, perfectionism, and control. Pencil has to be kept like this and this and this in arranged in orderly manner. Books will be kept like this. Cupboard will be like this. This is obsessive compulsive personality and not actually a disorder. Autism spectrum we have already taken care. It is not communicating. These people are not communicating. They have a repetitive behavior. It comes early onset in the childhood. Childhood. Okay. ADHD, inattention, hyperactivity, but the examiner is asking what? Treatment with methylphenidate or amphetamine. Very, very good. Intellectual disability, IQ less than 70. According to the Mental Health Act, it is now termed as a intellectual disability, and it is a functional defect. It is now not said as a mental illness. Learning disorders, dyslexia, dyscalculia, dysgraphia. Okay, graphia, that means handwriting. Calculus, no calculus. Dyslexia, you already know, the very famous movie. That is, I mean, but tick disorders, another movie which has been framed on tick disorders. Hitchkey. Involuntary, sudden, rapid, recurrent, non-rhythmic movements, vocalization, and has to be treated with antipsychotic. Now, what is it? Involuntary. It is not voluntary. Okay? It is rapid. It is rapid, recurrent, बार and non-rhythmic. कभी यहाँ हो गया, कभी यहाँ हो गया, यहाँ हो गया, यहाँ हो गया. No rhythm at all. Okay? Tourette syndrome. Very good. Tick disorders, Tourette syndrome. देखिए, आ गए हम प्रिया जी. टॉरेट सिंड्रोम के ऊपर मल्टीपल मोटर मोर देन वन वोकल टेक एंड लास्टिंग फॉर 1 ईयर. ओके. टू रेट में कितनी बार टी आ रहे हैं? 3 बार टी आ रहे हैं. वन इज फॉर अ मोटर टेक, वन इज फॉर वन वोकल टेक, एंड वन इज फॉर मोर देन 1 ईयर. ठीक है. दिस इज द वे हाउ यू रिमेंबर Tourette syndrome. Tourette syndrome, three T's, one for the motor, one for the vocal, and one for more than 1 year. ठीक है. Enuresis, we already know. After the age of 5 is the criteria. Behavioral therapy, desmopressin, imipramine. Now, encoparesis, new thing. Involuntary defecation after the age of 4. After the age of 4, now the person is not able to know that I have to do a certain activity in the washroom. It's doing it involuntary anywhere and everywhere. That is known as the encoparesis. ठीक है. चलिए आगे बढ़ते हैं. Sexual dysfunction includes erectile dysfunction, happen at the orgasmic phase. ठीक है. And treated by CBT and prostaglandin E5 inhibitors for the erectile dysfunction. And that is being framed in the NEAT PG at least 5 times, and for the FMGE at least 3 times. Okay, very, very important. Prostaglandin E5 inhibitors used for the erectile dysfunction. Paraphilias, deviant sexual interest, requires distal impairment to the diagnosis. This has been taken care in the FMT as well, so we are not discussing in detail. And INICT also, very good, Anand Panchi, has been asked in the INICT. INI got the favorite question. I guess it's 2021 and 22, so I guess it's 2 to 3 times if they have asked this question. Now, Gender dysphoria we have discussed, suicide we have discussed, non-suicidal self-injury. Now, this is very important. Again, you should know certain thing about non-suicidal self-injury. It is intentionally. We are doing intentionally. It is self-inflicted. We're talking about hesitation, cuts, harm without suicidal intent. We don't want to harm ourselves, and it is seen in the borderline personality as RFG mentioned it correctly. Psychological defense mechanisms are used to cope up with the stress and anxiety, like we do repression, we project on someone else, we deny that we were not here, we become submissive. Now, transferring. Patient projects feeling about the significant others onto the therapist. And there is another one, counter transfer. When the doctor develops a feeling for the patient. ठीक है? कौन सी मूवी याद आई? डियर जिंदगी. Alia Bhatt develops feeling for Jahangir Khan, played by Shah Rukh Khan. Patient projects feeling about significant others onto the therapist. Transference. If Shah Rukh Khan would have developed the feeling, it is counter transference. Okay? Done. Dear Zindagi. Very good. Okay? Done, done, done. Inside is the awareness of one's illness. This is a definition based question they are asking in the examination, seen in many psychiatric disorders. Okay, in the OCD, what is preserved? The insight is preserved. In the OCD, see, we have already taken care in this session that we revise on this spot itself. Insight is preserved. Very good, Arav and Anilji as well. Harvey, mini mental status examination. We've already taken care. Cognitive impairment, maximum score is 30. Less than 24 suggests dementia. That is the question examiner might ask you. For my friend who was asking about mental status and mini mental status. So this is mini mental status is the compact form of the mental status examination, easy to assemble and ask for the patient. Criteria having points till 30. If less than 24, it suggests dementia. Okay. Neuronoptic malignant syndrome, we've done. Serotonin syndrome. Coming to the serotonin syndrome, agitation, confusion, hyperthermia, too much of heat, too much of tremor, too much of tremor, and then landing up into the clonus. Clonus. Okay. This is the clinical sign for clonus. Treated by stopping the agent. Stop the agent, provide supportive care, and cyproheptadine. भूख बढ़ाने की दवा की तरह यूज होती है साइप्रोहेप्टिडीन. ओके. Tardive dyskinesia. Question can come up here. Involuntary movements from the chronic psychotic use treated by stopping or switching the drugs. Tardive dyskinesia, akathisia, agranulocytosis, that will come up in the examination. Coming to the akathisia, subjective feeling of restlessness, we've already discussed. Propranolol is the treatment. Benzodiazepine is used for the management. Okay, coming to the last few slides. Acute dystonic reaction is muscle spasm post antipsychotic, and it is treated with anticholinergic. Okay, so you're giving an antipsychotic drug and then you're landing yourself into a muscle spasm, and this is being treated with the anticholinergic drugs. Okay, very important. And acute dystonic reaction will present as a case based scenario in the examination, that a focal spasm of forearm has been seen after treatment with antipsychotics. Okay. Now, antipsychotic side effect, weight gain, we already know it happens by weight gain. A person like looking golu golu, ठीक है, happens by olanzapine. Okay. If it is having a weight gain, it happens by clozapine also. Okay, clozapine and olanzapine. Olanzapine. ठीक है. Diabetes, dyslipidemia, agranulocytosis. Clozapine, we already know. Agranulocytosis. Weight gain, you can easily correlate diabetes mellitus and dyslipidemia. Dyslipidemia. Okay, so weight gain, diabetes mellitus, dyslipidemia, and clozapine, olanzapine, agranulocytosis. Okay, so 1, 2, 3, and 4. Easy enough, guys. Okay, seizures also. Yes, seizures also. So fifth one is the seizures. Okay. Now, extrapyramidal side effect, dystonia, aphasia, tardive dyskinesia, already discussed. So that is all about today's session. So in today's session, we've taken care of the PYQ, the one-liners, all the one-liners. This is the total content of today's session. Third is the case base scenario. The fourth one is your definition based question. Fifth one is the drugs. Sixth one is the ADR that we've taken care. Seventh one is the approach in the case. Eighth is the examiner favorite questions. Okay. So this 8 way we have studied psychiatry in a very comprehensive and a unique manner that we have already taken care in this session of about 3 hours. So this session is sufficient for NEET PG as well as FMGE, and mainly targeted for FMGE and NICET also. Okay, so after this session, what we you have to do is go out, have your dinner, and from tomorrow, when you are reading psychiatry, see the questions. Okay, understand the core concept of the question that becomes your PYQ. Okay, option A, option B, option C, and option D. At least one line about each option you should know that you will be able to rule out, and from these one line you'll frame out the one liners. And similarly, you will study all the questions which are available to you. You can watch previous recall session, you can watch this rapid revision session, and all the other sessions as well. Okay, so you will have PYQ. After each question, you will have a PYQ and 4 sets of one liner. Okay, that is total 5 points. And if you solve at least 100 questions, you get 500 high valuable points from those questions. And that is the way you should proceed at this 11th hour when the exam is just around the corner. Also, feel free to ask me any doubt, questions. This is Dr. Tilak Dixit, your psychiatry faculty. Contact me on Instagram at the right underscore the left. Okay, please mention your name, batch, your query or concern, or any tips that you require from my side. I'll be happy to help you. Do share the feedback of this session. Spare some time to tell me what more to include in the future sessions and what did you like the best about this session. Signing off at this time on your Sunday, wishing you a happy Sunday evening. Goodbye. Jai Hind.